Okay. I'd like to call this meeting to order because we have a lot to do and I'd like to get people out on time. Welcome. My name is Esther Chu and I am the first-year chair of the Oregon Cannabis Commission. I just want to start by asking for approval of the minutes from the last meeting, last full commission meeting. If you want to take a second to look them over, then I will make a motion to approve them.
I move to approve the minutes for the meeting day, March 21st, 2019.
Anybody second that motion?
I'll second the motion.
Okay, the minutes are approved. Thank you. The next step is if you could all turn in your binders to 2198. I just want to start this meeting. This is there's a lot of meat in this meeting, so I just want to anchor us by going back to the mission for this Cannabis Commission. So I'll read the main 3 points. So the original language for the goals of our commission, it's that the Oregon Cannabis Commission shall determine a possible framework for the future governance of the Oregon medical marijuana program, including proper oversight and regulation. I'll speak through some of the details. Necessary amendments to the laws of the state pertaining to cannabis, the future role of the commission with respect to the possible framework. We also shall determine steps the state must take, whether administrative or legislative in nature, to ensure that research on cannabis and cannabis-derived products is being conducted for public purposes, including the advancement of public health policy and public safety policy, agronomic and horticultural best practices, and medical and pharmacopoeia best practices. And then finally, the commission shall shall submit a report in a manner prescribed by ORS 192.245 to the interim subcommittees of the Legislative Assembly related to health and judiciary on the findings and determinations made by the commission. Those are the main points, A, B, and C. So let's just stay anchored in that as we sort of work through the reports of the subcommittees. So we're going to move directly into the meat of this meeting. And so for those of you who have been following along, we decided that given the breadth of this commission and our objectives that we would split up into 4 working groups or subcommittees. These are product integrity, research, education and training, and patient access. So our subcommittees have been working very hard, have had separate meetings that have been productive and very interesting, and have drawn from expertise around the states. So today is where we come back. The goals for this session were that we outline the recommendations made by each subcommittee that fall within their purview. I know there will be some overlap in content, and then get feedback from the entire commission about those recommendations, how well they fit under the objectives of this commission, and how practical and feasible they are. I've been actually giving monthly reports to the governor's office, and I will just say a couple of points of feedback is we are advised to please be focused on the feasible, not to be too pie in the sky, because I think they would like recommendations that we can actually implement that move us forward, that are not so lofty that they are wonderful, but nothing will change. They also do want us to evaluate the framework of the Oregon Medical Marijuana Program and make recommendations specifically about that framework. So that the framework piece doesn't fall under any of our 4 subcommittees, but we do have a separate section at the end of the individual subcommittee reports. So that may or may not be something that we can address within this meeting. So we'll either tag it on at the end of this meeting or we'll start with it on our next commission meeting. Okay. Any questions about what we need to accomplish today?
I have one comment. In 2198, Section 6 also provides a couple of things this committee has to take into account, which is develop a long-term strategy, strategic planning for ensuring the cannabis will remain therapeutic and also affordable.
Thank you.
And then I do have one question. Could you repeat the last part of that two-part thing from the governor's office? Focus on feasible LPs.
Make a comment for how the OMNP is structured, sort of like the framework of the OMNP. Consider other models, like should the structure, the way the OMNP be run, should that be housed under the same roof as the administration of the recreational cannabis program? So the report that the staff pulled together for us will look at some other models from other states, just so they've been run through the exercise of seeing whether there might be a different model that would serve our OMNP patients better. I think it's, it may be that we review all those models, we consider pros and cons, and we end up with what we have. But they want us to sort of go through that discussion and be thoughtful about what would serve patients the best.
Well, we have to keep in mind that Oregon has been the national standard for the last decade at least, so it's always good to review and see what we can add to our program. But we've been a preeminent program that a lot of states have modeled their programs after ours.
Yeah, I think the big question is, in this new world of recreational cannabis, is there any argument for housing both under one roof?
And I would
Not
say,
a critique of
yes,
the
even though I know we don't want to go here, if we had started out that way. But by ushering adult use under the OLCC, I don't think we're going to see a medical model go under the OLCC.
So, we're already talking about this issue. I think we're going to talk about it later, but I just wanted to make the point that what's been in effect in Oregon for 20 years is the medical card program, which is a little bit different than dispensary. So when you think about the Oregon medical marijuana program, it's not just sort of one, it is one program, but there are a number of different aspects. So it might be with some aspects, for example, laboratory regulation on that. We work closely, obviously, with OLCC, but I just want to, it may not be all or nothing. So just when we think about it, cards are a little bit different than dispensaries, are a little bit different than, a number of things that fall under the medical and or the retail programs.
Yeah, I think we're sort of under like turn every rock phase. Are there any gains to be had anywhere here for patients? Can we be innovative, or at least go through the process of thinking through things that don't feel intuitive? So,
But there's two issues there, right? There's the administration and the regulatory side, which could be housed under one roof. I honestly have never understood why any state would opt for a dual model. Doesn't make sense to me in my mind. But I think the care of patients is a little bit different. I think they definitely engage with one another, but I think to your point, Katrina, and yours also, yes, they're sort of separate. We're going to have to tease them apart separately and see where we can bring them back together.
If I may, it was the intent of this commission to keep those two programs separate. There is some room for combining some of the things. Of course, packaging and labeling, testing, those sorts of things can definitely, and already do serve both communities, but we formed this commission to make sure there was a bright line for everybody between medical and recreational. And it's going to be problematic to really try and merge those two into the same agency. Not that it can't be done, but the blowback you're going to get from the medical growers and the patients and the caregivers is going to be good size.
this is exactly the discussion that I would like to have and the governor's office would like us to have, but not yet. So let's just hold those thoughts, and we'll come back to them either at the end of the meeting or the next session. Oh, the last piece, I forgot, I'm sorry. The last piece from the governor's office is a request that there be a patient representative on one of our subcommittees. So just to, and I appreciate that you are a patient representative, Anthony, but I think they felt like to be comfortably, have those voices comfortably represented felt like a good thing to them. So if there's room on any of our subcommittees for another patient voice, and if we have, I would just like you all to consider that, and it would be really nice to add one more. Okay.
Patient Access Subcommittee, we have 3 patients originally seated on the subcommittee, and we've added 2 more.
Perfect, okay, so that may satisfy that requirement. I think once we get the full rosters to the governor's office, they will see that that's represented, but I just wanted to make sure.
Are you asking for a patient to be on each subcommittee?
I'm not at all. No, I just wanted to make sure there was adequate somewhere in the subcommittees. It wasn't a good fit for mine, otherwise it would be there already.
Well, one of the things that I, as an independent person prior to this commission, I really kind of shied away from bringing a lot of patients into the legislature to go through all the hassle of getting there and getting home for 2 minutes of testimony, or to sit through 4 to 6 hours at a meeting like this. I never wanted to ask them to do that. And so that's why I picked people that are patients but are able to come and sit through 4 hours or get to the legislature and work with the legislature. So that's why I picked the patients that I did.
Yeah, and for the training subcommittee, I didn't know if patients were necessarily a good fit for every single meeting either. But I think it would be important, Anthony, for maybe some of the patients that sit on your committee to come into my committee as well. And I think a lot of us need to sit in on each other's meetings and provide real-time feedback. But I think it would be important to get the patient's perspective on the clinical experience with the physicians writing their authorization. So if we can make that happen, that'd be great.
Could we just, I guess for people who are calling in and those in the room who haven't been here before, could we just go around the room and introduce ourselves so people know who's on the commission and who's here?
Tom Jean, Deputy Health Officer, Public Health Division.
Jeff Coons, I'm the Deputy Chief of Police with the Kaiser Police Department, and I'm the Law Enforcement Representative for the Commission.
Katrina Hedberg, State Health Officer with the Public Health Division.
Anthony Taylor, President of Compassion Oregon, and patient seat on the commission.
Dr. Rachel Knox, founder of American Cannabinoid Clinics and co-chair of the Oregon Cannabis Commission.
Andre Russo, Center Administrator for Health Protection, OHA, and OHA's representative on the Commission.
Jesse Sweet, agency representative for OLCC.
Carol Yan, I'm the section manager for the Oregon Medical Marijuana Program, staff assistance.
Shannon O'Fallon with the Oregon Department of Justice advising the medical marijuana program and the commission and OLCC.
Okay, so let's go into the reports from each of the subcommittee. I just would like to hear. Oh, I'm so sorry. Everyone has on phone. It's bad. Sorry. Other introductions from callers?
I had just received, to interrupt, I just received a note that said the number wasn't working. Could I get that again and text it over?
Matt, are you on?
I am not indeed.
Can you introduce yourself?
Sure, Pat Lepke, Senior Public Health Officer for Lane County and the Chief Medical Officer for our Community Health Center Clinic.
Thank you. Okay, I think we're ready to dive into presentations from each of the subcommittee leads. I would like to ask for a volunteer.
Sure. Okay, Dr. Rachel Knox here, head of the training subcommittee, and this is training for medical professionals, particularly those writing authorizations for cannabis use in our state, but also other allied health professionals who may engage with patients and can help in the clinical management of patients on cannabis therapeutics. So our first action item is to administer a survey to the current OM&P providers, assessing their understanding of the OM&P program, their preparedness to participate in the program, but also their clinical competency, so their clinical preparedness to engage with patients, not only at that first encounter, but in an ongoing fashion, as though they were managing a patient long-term on cannabis therapy. And then we also want to identify the educational gaps, if you will, that are present currently, as well as assess the desire for, or what type of training program they might like to see in the future. We have reviewed what other states have required of their doctors authorizing for the use of cannabis, and some states don't have any requirements, like Oregon. We don't currently have requirements for training or continued education. We strongly suggest that doctors who write authorizations get some continuing education credits on the subject matter, but we don't require it yet. Other states do and are aligned with some pre-existing continuing education programs that we felt weren't necessarily up to par with what we like to see for our providers in our state, and mostly because we really want to unify the language across not just the medical sector, but also the adult use sector, because we know that people, not just patients, but consumers, are going into dispensaries asking medical questions, even though they're not registered patients. So unifying, standardizing the professional and medical language that we use is preeminent, and then obviously clinical management moving forward for our patients is going to be very important, especially as research and the patient experience and training intersect. Moving forward, all these different areas are going to influence one another and going to really improve our program as they do. So with respect to the training program we'd like to see in Oregon, we are thinking about which route we want to take. We want to start with a pre-existing continuing education program, so at least we get some standardized training on board for the physicians. So right now, MDs and DOs who are writing authorizations in the state, or do we want to develop an original training program? We like the idea of modular training that clinicians can access online, that you can edit in real time as data and research it brings us more information, as well as holding seminars for our providers to come to in person and learn. Again, I have to stress from our program our belief that research is clinical data is going to make our training program better into the future, and no state really has taken upon themselves to develop their own training programs from scratch. So I think we have a really good opportunity here in Oregon and with this commission and the deliverables to legislation to get something on the ground that we can work with. It's going to take some time to build. I do have experience in building some training programs. It does take time, but I think as long as we work hard to figure out the infrastructure that we'll need to get this done, I think we could come up with an original training program for our providers in this state. And then while we're focusing on healthcare providers, we do want to implement training for the adult use sector as well, so that the people in dispensaries, dispensary owners, cultivators, processors, everybody in between gets that standardized training, so that when patients come to their doctors and they're discussing with them what they talk to any of those other folks about, their doctor understands, or when their doctor gives them information, they can go back to the dispensary, whether it's an adult use or medical dispensary or not, and everybody understand what that customer, that consumer is wanting and needing. And we, in our meetings, have identified some of the subcategories that we feel need to be the core competencies, but that's rather lofty, and it probably wouldn't even benefit our recommendation to legislation at this point.
So Dr. Nash, just a question for you. So do you feel like, I know you started out with saying that we needed a survey of OMP providers, and that we need to consider how we're going to administer the training program that is developed, whether it's their existing professional education works or not. I guess my question is, for year one, do you think it's more seek and find? Is it sort of survey, more exploration, and spend a year knowing, trying to explore how exactly such a program would be implemented, or do you think there's like a year one legislative ask?
I think year one legislative recommendation as opposed to an ask, because we have to put time into our own personnel needs. So if we are going to develop our own original training, which I think everybody on the subcommittee feels would benefit our providers in the state, it is going to be a year, maybe, and even ongoing, in developing what we might think of as a robust turnkey program. That could even be replicated in other states. So it is going to take some time. But I do think, and we'll have to discuss this, like how important is it for us to get a training on board? There are pre-existing programs that we have discussed in brief. Whether or not that is satisfactory, we'll have to, And so that may be a legislative ask. I think we're just teasing that apart. And we'll dissect that a little further at our next meeting. Because I don't want us to get into a circumstance where now we've aligned ourselves with a program, and a lot of these programs that do exist, they aren't up to date. What was one of the criticisms that we heard at our last meeting. And so if we have no control over that content, is it something that we want to align ourselves up front? So maybe, I guess my answer to that is maybe.
So, thank you. Just to kind of understand, there are the medical providers, and that's this Cannabis Commission here is focused on medical patients. You also said something about the people who are working in retail dispensaries. So, again, who's the target audience? And then I would ask Carol, I'm not up to date on what the statistics are, but we know the people who, and it has to be physicians, but who recommend use of cannabis, and they, if I'm not mistaken, fall into kind of categories. There are some who have quite a few patients, and that's been their focus, such as yourself, and then there's some who have a bunch of patients, forget the and then there's some who have one or two. And so, again, trying to figure out who the target audience is and what the purpose, but at least for the discussion here, I'm just trying to understand what the conversation was. So I get that more people need training, but it's sort of who and at what level and how do you assure, or is it just that people ought to do this and therefore you develop something, or that you're requiring it, or anyway, I'm just trying to figure out what the discussion was.
No, that's great.
Training is fine, but the legislature is going to want, okay, how much money to whom, and do we require it or not? Or I'm just thinking of other things like that.
Right, and we've talked about that, and we'll have to get those numbers out. But when we're talking about patient access, we're not just talking about affordability and their existing a dispensary. Access to quality care is important too. And when I have patients who have gone to another medical provider in the past and just wrote their authorization and didn't give them any clinical guidance in their cannabis therapies, or told them wrong information, and then they come to see me and I have to re-educate them, there's a problem. We don't have the board specialty of endocannabinology just yet. It's coming. But how do we make sure that the patients that are engaging with clinicians and getting authorizations are getting the same information? And that's really important and really glaring to me when I have patients coming into our clinic and telling us that the person behind the counter at the adult use dispensary was giving them medical advice. One, that's unlawful. Two, that's a liability for a dispensary. So we are absolutely going to get into the language and the training of the people who are engaging with the patients at the dispensary level, adult use or otherwise, because they do need to be trained in what they can and cannot say or discuss with patients so that they're not held liable. We haven't seen anything happen yet, but the first instance where a consumer complains that they got medical advice from a bud tender that harmed them, it's going to be a huge liability for that dispensary. Right? So how do we protect dispensary owners from that fallout? Well, we train. So we need to have uniform training, and to the extent that people get training, that can be variable. I do think that it would behoove all of us to have a minimum requirement, and that's just doing our due diligence on behalf of the patient who is entrusting their care to a provider, and entrusting their care to the products that are being sold in dispensaries. So I think we owe it to our consumers for some baseline, fundamental, foundational knowledge. But endocannabinonology is coming, so I do think there should be an opportunity for clinicians to get specialized, training as well. Who should administer that? I don't know. But I do think it would be great to have a modular program that people can pick and choose, maybe some of the subspecialty areas in cannabis medicine that they could train in. Like if I'm an oncologist, maybe the module on cancer and cannabis is something that I might be interested in. That might not be interesting to a primary care physician who's writing an authorization, or it might be. But that's something else we're tackling, the minimum requirements and any specialized training that clinicians can seek after that. Does that answer your question, or sort of frame?
Jesse Sweet for the record. If I may, I'd like to talk a little bit about the existing law on training, because at least when you're talking about the retail employees at OLCC licensees, there's options here, and they don't necessarily have to be statutory. as a condition of receiving a worker permit, OLCC had a broad mandate to require training, but we didn't know what to require. So we developed a test for permit applicants that was all based on compliance with laws and rules, because there really wasn't anything out there. So I agree with the sentiment that we really shouldn't be having these retail employees giving medical advice, and that's a bad place to be. But to the extent that we can make that module of the training discrete, it doesn't necessarily have to be in statute. It can come through administrative rules through the Liquor Commission.
Esther Chu, so are there existing training requirements for physicians who authorize use of cannabis?
So we can answer. So Andre and I, we had a subcommittee, when was that, about a year ago, to look at basically what the recommendations for physicians who were recommending. But anyway, it was guidelines. But it did talk, just as Dr. Knox said, about what would be a good idea, but it did not, there are no mandatory requirements. Now, the state of Oregon doesn't have many mandatory requirements for training. There's been a lot of discussion around pain, and I think we all, when we get initially our license is like 5 hours of pain training, and that's gone through the legislature a number of times about do we need to update that and how many different and all this kind of thing. But we rarely have specific requirements other than general CME or CNE or what, whoever, and then the people sort of pick and choose which area of continuing education they would need. So this content specific, but again, it could be a recommendation to the legislature that if you are going to be one of the people who is recommending or authorizing a card, that you then do have some at least minimal understanding, minimum or whatever, but of the endocannabinoid system, etc.
As physicians, we understand not wanting to be told what all these things we have to do, we have to pay for. I empathize 100 and 1,000%. But the issue is we have to do our due diligence on behalf of the patients, and we really can no longer allow for misinformation to permeate. The other thing is what is coming down the pipeline. Endocannabinology is coming. It will be a board certified accredited field of medicine. It is happening. So are we going to sit around and wait for that to happen, or not? I'm not a sit around and wait kind of person. And so I think we can do a good job at an administrative level or a legislative level. I think we can set precedent here. The other thing is medical malpractice is coming down the pipeline for clinicians who authorize for cannabis use. That will be a thing. And so how are we protecting our clinicians? And they absolutely are going to require some minimum training. So again, this is us getting ahead and getting our clinicians in our state prepared for what's coming down the pipeline.
I'm guessing if we could get resources to develop some of these online modular training resources, that there's a hunger for it in the state. So I love the creation of it and making them available. Like I know that I and many of my colleagues would take it. I guess the question for me is, are we going to recommend that a specific group of people, those providing authorizations, have a minimum requirement within those resources we create? I think it's a fascinating idea. So that might be where we're headed. All right, any other comments for the Education and Training Subcommittee before we move on? Any other comments?
On her report.
Yep, on Rachel, Dr. Knox's report. All right, are we ready to move on? My next volunteer. Thank you, Jesse.
I would like to volunteer Andre to give me
He's the chair. I'll ask Jesse for his assistance when he gets that. So no problem. So we only met once. We didn't have a meeting in May. We don't have any legislative recommendations at this time, although we do want to look at the data production, include that in a report, and have the legislature review that data so they can tailor any legislative concepts based on supply and demand. Administratively, we had 2 priorities. So just to recap, our subcommittee is kind of divided into 2 subcommittees. One is product integrity in the sense of the product itself, so safety of product, and the other was more of a, I guess, call it diversion issues, for lack of a better term. So our administrative recommendations out of those 2 parts of the subcommittee would be to continue to evaluate the enrollment and use of CTS for the rest of the 2018. And we're coming up on some deadlines here. So July 1st, anyone that meets the criteria for tracking in CTS will have to be using the system by then. And if you're not, you still have to use the OMOS system. So to follow and evaluate implementation of CTS, so that would probably take the remainder of the year to provide some recommendations legislatively. Second would be to develop a random or audit testing regime for products. So that would be the involvement of OLCC, ODA, and OHA there. And OHA's involvement would be ORLAP. And within that would be to develop some sort of reference laboratory that could serve as an arbiter of test results done by private testing laboratories. Anything else? Yeah, Mr. Sweet?
I'll add a little bit on the request for data. We essentially are trying to find out 2 things. First, what is the total production potential of the OMP system? How many plants are growers currently authorized to grow in the state of Oregon? There's been a lot of discussion about overproduction and overproduction fueling interstate traffic, illegal interstate traffic. So we would like to get the best number that we can out of OMP, provide that number to the legislature so that they can make informed decisions about the legislation that they're considering. The second data point that we're looking for is designed to test how well the tracking in 1057 is actually working. So what we've asked staff for there is a list of the total number of growers and grow sites who are subject to CTS tracking under the legislation. And then after July 1st, an actual of how many of those who are subject to the requirement have actually signed up to meet the requirement. Those are the 2 initial things. And then once we get tracking going later in the calendar year, we'll be able to report actual numbers out of the metric system. But I think it's important to get that first point of participation rate before we provide any numbers, because the numbers are just going to be a snapshot based on the participation rate.
So I have a note to add. So on the first data point, it would be an estimate based upon max permitted within the medical system. So that would be the assumption of everybody who's growing 6 plus whatever poundage they're allowed to plant.
Correct. So that was the request. If every person authorized to grow medical marijuana in the state of Oregon was growing their maximum number of plants, how many plants is that?
It's about 10 million. Actually, this is Anthony. I ran those numbers a couple of months ago, and it's hard to use those numbers because I think when we get that right down to grow site administrators, the OHA has projected that there's about 2,000 grow sites that need to be registered with the grow site administrator to go into OLCC, and I don't think we're going to get close to that number. And those 2,000 grow sites serve about 15,000 patients. And so we really, really, really need to figure out how to get these people into the program to save patients, basically. I know turnout has been low so far at most of the meetings that OHA and OLCC are having. I'm doing everything I can to make those numbers go up, but it really exemplifies the financial strain and struggle that the growers are having to go through to provide cannabis for their patients, and it is reached critical mass in my opinion. I don't know how much lower we can go in patient numbers in and still support the plan, still support the program that's based on fee. I think we're dangerously close to that. When we get a chance, Carol gets to walk us through the numbers, but I think we're in crisis mode, and we really need to figure out what we're going to do here in the next couple of months to make sure our program maintains its integrity and its level of participation above what's needed to fund the program.
I just have the same question for you that I had for Rachel is, does it seem like we need a year of data collection and fact-finding, or are any pieces of this going to be a legislative recommendation this year? For example, public reference library, development of random audit testing, any of those pieces feel like they're right for this year?
So I'll speak to some of the data, and I'll defer to Andre on the reference testing. I think some of the data that we've requested is absolutely going to be ready for the legislature. The maximum number of plants that can be grown in the system, we can take a snapshot and provide that as a moment in time. And the same for CTS participation. We can absolutely provide that as a snapshot. And I think those would be important numbers that the legislature hasn't necessarily had before. But there's other data that I think will benefit from a longer time period. A year from now, we'll have better data than we have 3 months from now. But I don't know that that prevents us from making the recommendations to the legislature for this upcoming session, to the extent that those recommendations are just that they consider the present data in right-sizing OMFP and considering future governance.
I have a clarifying question. Is the overproduction problem in our state related to medical growers or legal adult use licensed growers?
Yes. There's overproduction in both systems, but I think what we're struggling right now is trying to quantify where the overproduction and where the export activity is concentrated. We essentially have 3 markets for marijuana, cannabis in Oregon. We have OLCC, OMMP, and illegal. So I think there's overproduction in all 3 markets, and but we're going to be struggling with trying to quantify that as we go forward to make better recommendations.
Okay, so with respect to OLCC cultivators and overproduction, and I was on, in the meeting about the canopy bump up and all that stuff, which sort of doesn't make sense to me when we have an overproduction problem. So are there any recommendations to, legislatively or to the OLCC with how to manage the overproduction within that system that could easily go to patients?
So OLCC will be working on a comprehensive report on production in our regulated system, and that will be delivered towards the end of this calendar year. As far as recommendations, I think really we have a wide open playing field as far as recommendations on how OLCC licensees could interact with patients and how they can subsidize the needs of patients. Right now, there are ways for people to do it lawfully if they choose to do it lawfully, but we don't really have, except for the bump up canopy, which has been really not used effectively, we don't have any incentives written into the law to incentivize redirecting surpluses to patients.
Where are the surpluses going now?
Same place they're going on the medical system.
Okay, so yes, that was a rhetorical question. I think there probably are easy solutions, and I never thought the bump up canopy was an appropriate solution. Why have licensees buy into more overproduction and then get to sell just a small portion? None of that made sense to me when we already have overproduction as a problem. So let's try to capture that. and reroute it to patients
Yeah.
lawfully.
I mean, I don't disagree with you. I've spoken with some people in the industry who are doing this charitably. There's mechanisms for doing it charitably. I don't think that there has been, based on just my anecdotal observations, I don't think there's been too much of that type of activity happening. I think there could be more, and you know, potentially the state could find a way to incentivize that activity.
Anthony here, to incentivize it, one thing that came out of our subcommittee was making a certain level of donation a requirement to get your medical endorsement through OLCC. And then the other thing I just want to touch on, there's 45,000 patients in this state. That means that the maximum they can produce is 270,000 plants. The formula that OLCC used to convert plants to canopy was 40 square foot per plant. If you figure that out, that's about 10 million square feet divided by an acre. Shows that the patients are growing about 270 acres of cannabis in this state. So that's about what's licensed right now. So if the retail producers are producing 1 million pounds, medical growers are going to be close. The medical growers will be close to that number. And since the state has basically shut off their market until they can get into OLCC metric system and try to transfer up to 20 pounds, and there's just a lot of product out there that we got to figure out how to make work for patients. Thank you.
One other data point I'd like to add to this discussion, which is not directly related to Anthony's statement, is that the sales at retail in the OLCC license system right now are about 12 to 15% to cardholders. So that's another thing to consider when we're talking about the way that the systems interact. The medicals, some medical cardholders are already being served through OLCC, and that's demonstrated by the data in the metric system.
Two other points. One is that the numbers I saw from OLCC show about 40 million in sales per month to consumers and about 5 to 7.5 for patients. So that's a breakdown. Then I had a comment on yours, but I lost it, so I yield.
So the second half of that for the random testing, so we currently have enough statutory authority that we don't need to make some recommendations as far as the authority to implement such a program. What we would be going to the legislature for would be asking for position authority and then a funding source to get to operationalize the random audit testing program. It probably wouldn't be a large ask, and that's by the extent of what we would ask for or recommend.
Is your subcommittee going to go into detail on what should be standard testing?
That's already in the rules.
Okay, or to make recommendations to that. And the reason I ask that from the perspective of a clinician is because there are things that I want to see on labeling that don't already exist, especially when I'm talking about medicine, right? Cannabinoid profiles are one thing, but terpenes are a whole other thing that can really make or break an experience with a patient on any given product or strain. And we don't currently report on the other molecules that are in cannabis, but it's going to be increasingly relevant as clinicians are becoming smarter, as the research becomes more robust. And when we're talking to patients about the chemical constituents of their products, that terpene profile is going to become even more important than the cannabinoid profiles. And so we would like to see stuff like that on the label. And so I don't know what route we would have to take to encourage that additional testing, but it would be more meaningful clinically for patients and consumers.
So right now, testing is for public safety purposes.
Yes,
we're setting
has to go beyond that.
Yeah, we're setting a floor as far as the minimum standards on what a label should be, and now OLCC has authority over labeling, and I think that their general position is to keep the label uncluttered and as readable as possible. So I would agree that eventually at some point, probably particularly medical grade labeled items, that you would want like a larger profile. But I don't think the time is right until we have better, I guess, research to inform what an appropriate label would look like.
Well, we have that with respect to chemical constituents.
Yeah, I mean, it's not gonna, I don't plan on adjusting the labels beyond what OLCC is amending the labeling rules right now, as far as this subcommittee's work in the first year. The priority would be to have a system where the state can audit or randomly test product that's either at the wholesale level or on the shelf to ensure that the product is safe, and then maybe in the future go into the clinical integrity of a product or the information that would be useful for clinical purposes.
I appreciate that. I'm going to push for it to happen more expediently, but thank you.
I think that's something we should keep on the table. You know, I think we probably won't get to it first year, but I can imagine a subcommittee that is clinical integrity, not just consumer product integrity. And we can play the sticker game next year and see if that rises to the surface. So I think it's a natural move on to Anthony's subcommittee. I'm sorry.
Okay, thank you, Madam Chair.
I'm sorry, I think Katrina had one.
Sorry, I had
one comment.
a quick comment to this point and the previous point. But it does strike me similar to the comment I had made earlier, is kind of who is the audience. So when Rachel was talking about the training that needs to happen, certainly there's what needs to happen for the physicians and the patients. So this idea of what are the constituents, what are the different chemicals, how might they react, that I'm not sure belongs on a label. Certainly when you buy other medications in the store, it's not all on the label. There's a package insert, here's this, here's that. And the question again is that training for the person who's recommending? Probably not. It's probably more the information to the consumer who might be buying products. So again, it seems like it actually fits a fair amount within the work that your committee is doing. I know that part of the issue we have when we're talking about the testing really is how many labs in the state are able to test, and what do they test for, and how much product, what do they need to sample, and how homogeneous is the product. In other words, there's a whole lot of things that need to happen in order to come up with a package insert, for lack of a better word. And so, you know, one of the things, and we've talked about this all along in all of our committees, one of the giant limitations when it comes to this is at the federal level, it's a Schedule I substance. And so you cannot do the type of research that has been done for other, you know, medications that are on the market. And so given that, and what are the boundaries? You don't want to have a requirement about all the labeling, and you don't have any laboratories that are able to, you weren't saying this, but you know, you don't have the laboratories that are able to test for it. So, so that was one point. The second point that I wanted to bring up is a little bit what Andre said, that I think in this report to the legislature, we do need to be clear about kind of what the ask is, for lack of a better word. Is it something we need statute, or do we actually have statutory rule authority? Are there things we can do with policy with the little p, and what we really need are some resources, or we need you know, some support behind what we're doing. So I think as we go through, we should be really clear. The ask is, you know, we have a lot of information we haven't been able to implement if you don't have resources. There are areas that are kind of a black box, and not only do we not have the resources, we don't have the information, but just going through, we want to be sure that we're not asking for something we can already do. So that might be kind of background, given that we're able to do X, Y, Z, what our limitation is, or the barrier. And I think we talked about that at meeting number 1. When we're talking about sort of the role of this commission in responding to specifically the legislature, what's the current status, and what are the barriers that's preventing us from doing research, you know, more product for patients, more labeling, more testing, or whatever, and to be really clear whether it's, forgive me, just money, because just money is a lot more than that, or is it resources, or is it ability, or is it the science behind it, or, you know, what are the barriers and how can we potentially address them?
Yeah, and with respect to what's clinically relevant on that product label or not, that is important, because when providers are talking to their patients about the parts of the cannabis plant that will benefit their medical problem, they want to be able to go to the shop at the retail outlet and get a product that fits that description. Right now that doesn't exist, and it's actually really simple to turn it on. But maybe it's just a market differentiator. You know, maybe I'm speaking to the people watching right now who are processors or do packaging, because there is precedent. You know, in the state of Washington, there's great companies that label absolutely every single terpene that's in their product. And that's a differentiator. They're going to make money because people are going to be able to go to that retail shop, get that product, and it's going to say exactly what the doctor said. So maybe that's not something that we have to spend a lot of time on, but somebody needs to hear me today when I say that, because it's going to make you a better business person.
There are growers and retailers in Oregon who do this voluntarily as well.
That's a differentiator. They're the ones who are going to stick around.
You know, the other thing is that the more testing is the more cost to patients, because their growers or their wholesalers or whoever is going to have to step up and pay for that testing, so we have to keep an eye on that. With respect to one of our guidelines is make sure it's still affordable. The other thing is, in response to what Katrina said about the research, yeah, there's a lot of barriers in this country about research, but there's a lot of research being done in other countries that we can look to, because it has just been almost non-existent for cannabis research to be done, and certainly for human trials and all that. So we have to look outside the United States for a lot of the research that we're going to yield.
Yeah, and I'll just point out that, I mean, our goal for the next time this full commission meets will be in July, and I think, September is coming fast, so the goal of July will be to really filter out what is the ask, so to sort of distinguish what we need to have and what we already have authority to do, and then the parts that need to be to lead to legislative change and an associated budget with that. So anyway, that's what we're pushing towards. I think we're getting there, but we're not quite there yet. Right, so Anthony, I'll move to you.
Thank you, Madam Chair. Patient Access Subcommittee is a two-part committee. We're supposed to look at patient access, and we're also supposed to look at streamlining, restructuring, and expanding the program. So what this subcommittee has begun doing in its second meeting is focusing on the patient access aspect of our duties. So we're going to focus on the patient access, of course, and we started off our last subcommittee meeting by talking about patient surveys, target date for the completion to be year's end, which method should we use for the survey, and if it should be for existing patients or patients that have left, and also how can it integrate with other subcommittees and their questions for surveys. The general consensus was that it should focus on people that have left the program, but consideration be given to the ability to contact those people. That could be an issue. And then, of course, method for conducting the survey is still being discussed as it relates to cost and ability to maintain as primary considerations. Andre gave us some feedback on the costs of doing mailings and things of that nature, so we're going to still keep that on the table for consideration. Then we moved into patient access conversation after that. We discussed various approaches to who would qualify for reduced cost and or free medicines, and how to get those medicines to those that need it. There's several subsets of patients, including those that already receive a reduced fee for the patient card. Kind of along with that is those that are paying their full fee. Also, those OMNP patients that are in the Oregon Health Plan, and how that may work. Creating another subset is those that need medical grade products with no interest in growing, processing, or selling, and finally those unable to meet financial costs of being in a program / falling through the cracks. Other things we considered were growers' ability to give away to any patient. I'm going to digress back to our conversation a little bit before, because Rachel was asking about this bump up and all that. That really came out of efforts by the OLCC and patient advocates to create legislation that would allow OLCC producers to just give directly to patients. That was, 2.5 years ago? We tried to get that, and we ended up with a bump up canopy. So there's other things to consider rather than adding the canopy, but designating part of your existing canopy and a number of things. But most of the medical growers or OLCC producers aren't participating. It's more work for not much return. We also talked about, for patient access, expanding the list of those that can sign the APS, talking about naturopaths and nurse practitioners. Also, we had a brief discussion about the nonprofit dispensaries, but more in light of the way patients were evaluated to determine if they could get access to a reduced program. And the nonprofit dispensaries had a way that patients could be at or below the national poverty line, but that designation was to be determined by the dispensary, which, as Andre pointed out, not much of a path forward. And then how to incentivize the OLCC retail outlets to participate, and finally the ability of the state to subsidize the costs. And then I also provided the commission with a number of survey questions that could be asked. Quite a few survey questions, mostly so everybody can see kind of where we're coming from and what other questions could be added to this survey to expand it. I'm not sure that, we're talking about having this done by year's end, so I'm not sure how much of that data will be available for our legislative concept proposals for the report back to the legislature. But that's kind of our target date. So the first meeting, I would add that Dr. Chu sat in and she tried to put it all into context, which is, if you had $3 million, how would you make this work? So we're kind of using that as our background on how to proceed. We do want to keep in mind policy versus legislation and what can be done administratively rather than going to the legislature, and in keeping those asks reasonable. I don't want to get bound up in asking for stuff that just out of our reach, at least at this time. So that's about all I had for my report, although there is part of our subcommittee looking at what's going on legislatively, and the OHA is currently working on their draft rules to implement Senate Bill 1544. And one thing that the commission, I think, should be keeping an eye on is what they're going to propose, because right now there's a roadblock in our 3-to-1 ratio for immatures. That's a big stumbling block right now, is the ratio of immatures under 24 inches to be able to better serve the growers for these patients. We have not seen a final draft. I'm not sure when it's going to be available, but we should take a look at it to make sure that these immatures under 24 inches come out in favor of the growers rather than the agency.
Anthony, you made mention before, I think in comment to either Jesse or Andre, about the number of patients at present and looking, projecting into the future, not being able to sustain the medical program through patient fees. Have you guys discussed outreach to the general population here in Oregon? I, for one, know that I continue to see patients who are becoming patients for the first time. So I know there's still a lot of people out there who are considering jumping into the program. And, I suspect that a lot of people just don't know their options or their why, and maybe even incentives to get them into the program.
Yeah, I do hear that also from other clinics, that new patients are continuing to come in. I'm not sure how many we'll see in the next quarter, if we're going to lose or gain, but we really are, I think, at a critical point in this program where we've got to take some action pretty quickly to keep it from caving in on itself. We'll know more after we get the budget presentation, but I'm a little worried. I'm a lot worried, actually.
So my recommendation is to talk about outreach in your subcommittee.
Yes, I'm sorry, I didn't really answer your question. We have talked about it. I'm not quite sure how to go about it because the OHA has, over the years, not advocated for either the program or its patients. So I'm not quite sure the path forward, but we are discussing it.
So if I may, on the outreach question, I think there's some strategies that any organization can employ when they want to get some information from its participants. One would be focus group. Here, I would think that a comprehensive survey of our existing patients would provide us a lot of answers that we're asking. I think that's probably the best route that we have available to us now in developing a survey, because I sit here in public health and my background and of all the professionals I work with, I would want a survey to be as objective, scientific as possible, and generalizable to the population that we're asking the questions of. So administration of a survey is not an easy task, but I think that we have the tools here to do it. And then I think this commission can evaluate questions that they want the survey to ask. And I'm looking at Katrina here, but I think that there's a way that we could utilize the resources here in public health to develop the survey and help administer it. Of course, cost is always an issue, but I think we have the resources and tools here to develop a survey that's going to be comprehensive, objective, and answer a lot of our questions.
Which is great, but by outreach more specifically, I mean marketing. Getting new patients into the program.
It's just not a function of this government agency to market and to provide some sort of incentive for patients to join a program. It's like does the Department of Motor Vehicles, want more people to get driver's licenses? No. I mean, that's the same function, right? It's an agency that administers a registration program and regulates the aspects of that program. It's not a business. It's not like Business Oregon, which has a different mission. So, if you're an outside person or organization, you can sit there, like Compassionate Oregon, you can sit there and advocate that you need more patients to join, that it's in their best interest to use cannabis for therapeutic purposes. That's fine, but a state agency, that's not their function, and we just can't do that.
That is fine, but to be clear, we're trying to develop a program for patients. That means making this program better for existing patients, and yes, getting more patients into the program because we have research incentives now. We want to glean information, and not only that, we want to provide good medical care to patients. It's like, I've worked in hospitals, right? There's an incentive to get patients into the doors, which is crazy because the hospitals where you treat sick people, right? So why do we want to market to sick people, get more sick? We want people to get well. Pharmaceutical companies are another, they're constantly marketing to people, to the consumer about their products. I'm not saying that's what we do, but I think we need to think about outreach. If funding the OMMP is in crisis, well, then we have to come up with solutions, and outreach is one of those solutions. If we need to collect more fees, well, that means we need more people entering into the program. So I think that is something that we have to think about, even if it makes some people uncomfortable, or even if it's sort of outside the scope of our commission, it needs to be talked about. And I don't think there's any problem in soliciting patients into a program they're going to benefit from medically. But again, we're talking about cannabis as medicine, which means we're helping people address their medical needs, health, healing, and wellness. That is our ultimate outcome here, even though we're talking about training and research and diversion and all that. The person at the end of this program is the consumer. And that consumer, in this case, is a patient looking for an alternative to conventional medical therapies that isn't working. So at every single meeting, if we do not place this patient first, I'm going to bring it up, because right now we're talking about patients' access to medicine that does help. And we have the research that exists worldwide that supports that. So that has to be our preeminent focus. So if we have to come up with some way to help get more patients into this medical marijuana program, let's do it.
See, I'm going to disagree. And on a personal level, I'm not going to disagree, and I'm not going to put my opinion on the therapeutic benefits of cannabis into this conversation. As a representative of this agency, I'm going to thoroughly disagree with you, is that this agency isn't here to promote patients joining the program. People talk.
Your agency?
Yes, that's right.
Okay.
And that's the agency that's administering this program. So, and people want to talk about we don't have enough patients and we need more patients. We don't know that. We really don't. We don't know if 100,000 medical marijuana patients in the state of Oregon is the right number. We don't know if 45,000 patients is the right number. And I'm going to propose that whatever the number is the right number, because the reason that the patient is in this program is because they had a discussion with their clinician on the benefits for cannabis for a particular therapeutic purpose, and the clinician said, hey, I think you should try this out, and I'm going to sign this form for you because you brought it to me and you want to be part of this program. That's why we have patients. It's a choice that people are making to use cannabis, and then they're having a private discussion with their physician on the use of cannabis. It's completely different than signing up for OHP or Social Security or something like that. I mean, so when I hear that we don't have enough patients, we don't know that. We don't know. And we don't know until we start collecting data. And it's very frustrating to know that we need more patients. Well,
I don't think anybody said that we need more patients. It was an if, it was an
said for the past, since I've been here.
Okay, so let's just pragmatically, right, if OM&P runs off of fees and the patient numbers are dwindling, well then there's not enough, there may eventually not be enough money. I don't know the current state, again, we have to collect data, but that every patient has a clinician who's willing to talk about cannabis with them is highly inaccurate. If we are going to sit here and just accept, that patients enter the program because they had a meaningful conversation with their well-intending clinician, that doesn't exist. We still live in a society where clinicians are staunchly opposed to their patients using cannabis, despite the literature out there, despite it.
Then that's okay. It's okay in the sense that this agency isn't trying to change that on a policy level. And Rachel, personally, you and I are probably not too far off in the way that we believe things and in our opinions. But that's not why I'm sitting here at this desk. It's not for my personal reasons or personal opinions. And I just don't think that we're seeing, we have this cognitive disconnect on what the purpose of this program is for. And I just don't think that, I don't really want to engage in that conversation right now. But I think, well, it's going to take a lot longer. We're going to consume people's time. That's not fair to everybody else. But I would like to sit down with you on a private level, and we can have that discussion about what the purpose of a government agency is and the purpose of a private organization that does advocacy work. No, I'm not, because there are a lot of private not-for-profit organizations that have the ability to advocate and to promote and to market, but this agency doesn't have that advantage.
Yes, so yes, I understand you're the administration body, but these are still conversations that we can have and Anthony's subcommittee can discuss, right? Discussing outreach. And how do we do that pragmatically within the constructs of these agencies, what they can and cannot promote publicly? We need to start having those conversations. I don't have the answers, but I would just like to recommend that outreach be something that is discussed. We want this program to be great for as many people who want to enter into it as possible. We don't want to limit the number of people who enter into the program. We also don't want, we want to be able to control it and allow it to grow and scale. We want all of those things, but a part of wanting to grow and scale is getting people into the program for the first time. And so maybe the conversation is how do we create a program that we don't have to solicit, right? We don't have to advertise for, that is compelling enough on itself to bring patients in. Maybe that's what we're talking about, right? But we just didn't.
I would agree with the first part of that. We want a self-sustaining program that is going to provide the benefits of being a medical marijuana patient or cardholder, and we want that to flourish. But every time someone says, we don't have enough patients and we need more patients, based on what? It's just like, what?
I'm just worried we're getting into a little bit of a loop there, and
Yeah.
I would love Katrina's thoughts, because I know she's been chomping at the bit, and then I have a wrap up.
Yeah, so I think, obviously, I also work for this agency, but I do think it's really clear, and it's true for a lot of the work now I'm getting, 10,000-foot level about roles and responsibilities of different organizations and agencies. So I'm a physician, but I'm not a clinician. So my expertise has gone into epidemiology and public health and those kinds of things. So again, I'm every bit as much a physician as other people. I just don't have expertise in one area, I have it in another. So being really clear about the role of government, regulation. Again, we're a government health authority. We've got police here, part of government. We've also got OLCC here, part of government. Different than advocacy, different than patient, different than clinicians. You all are clinicians and obviously expertise. So I think we need to be really careful. And the things that are written, so I always go, so what is the statutory framework for this commission? And I didn't see anywhere that it said marketing, cannabis as a safer alternative to, let's just say, opioids, right? And lots of people have proposed that, and there might be some data that for certain conditions, yes or not. But again, that's not our purpose. Our purpose is to make sure people get information, that however the regulation is, it's done within a framework. It's as a framework for the program, what research is needed, et cetera. So I would just bring us back on down to specifically what it is. And again, I'm not disputing that certain people and or organizations might feel strongly about there needs to be more, there might be others that need to be less, etc. I don't think the purpose of this commission is to decide that one way or the other. It's to really focus on exactly what the legislature said, what the barriers are, how we might address those, what the legislature, what we could do with policy, and not get into this discussion about are there enough patients or not. Again, I didn't hear you say that exactly. Last time we were here, we had public comment that there's, it's not overproduction, it's under, there's not too much demand, not too much supply, there's too little demand. And again, these are all opinions that might be valid. The purpose of this commission is not to decide yay or nay with that. It's to really be very concrete and address exactly what's in the statute.
I 100% agree with that, but to get to those answers, we have to have these sorts of conversations. We have to talk about some of the nuances of what is happening and where we want to see this program go. And we need to get down to the bare bones of it to then rebuild what we want this to look like moving forward, right? The reason I said the word marketing wasn't because I think we should market. I just wanted you all to have a very clear understanding in layman's terms what I was talking about by outreach. Because when I mentioned outreach, Andre responded with, we're going to survey the existing patients. So I knew there was a disconnect there. So I don't have a problem having sort of these more heated conversations because I need to know who each one of you are. And you need to know who I am. And we need to understand the why, our whys for being here. And yes, that's going to turn into exactly what they're asking for us. But in order to get there, do you see what I'm saying? In order to get there, we sort of have to have these more nuanced conversations.
Right, and my proposal is if we want to figure out what the patients want, let's ask them. And the mechanism to ask them is through the survey. And so if you have other outreach strategies, like a focus group, then I'm all ears.
So just one other comment on that certainly I know that this is related to the medical marijuana program and medical cannabis. It would be possible to have a survey of people at the point of dispensary because we know that there are a number of people who purchase retail marijuana for medicinal purposes. So you could actually ask them, even if they're not card holders, we could do at the point of exit or whatever, survey and say, so did you buy this? Are you buying it for? What's the purpose, etc. So there might be a way to capture that, but I would be reluctant to do kind of a broad outreach or marketing. Are you aware that if you're in chronic pain, cannabis might be a good answer or any, again, you weren't saying that, but I'm reluctant. You did mention the general population. I'm not sure about that, but there are enough people buying retail and have certainly heard about it that seeing how many of those folks are purchasing retail for medicinal purposes might be another population that we would be interested in capturing in a survey, not just the card holders.
Yeah.
I think what I'm hearing from you, actually, I think there's like a little bit of a difference in the language. I think, when we're talking about state agencies, and it's the same in academia, you say marketing and instantly like you know, the pH level in your stomach just drops. But I think what we're talking about, what I'm hearing from you is it's more an access issue. Like, how do people utilize something if they're not aware of it? And also awareness also tends to fall along sort of, it tends to in itself create disparities, and that's what Anthony's subcommittee is all about, is sort of like leveling some of these disparities, because access tends to always go to people with more privilege and more information. So how do you even that out unless you do some form of public awareness? But we just sort of keep that in parameters and feel comfortable with, you know, with the agencies we're working with and the purpose of this commission. So I think there's a more common ground than not. But you know, we'll engage in some of these little things around the margins where we tend to divide a little. But Anthony, I know you also.
Yeah, I just had a quick comment. The agencies can't promote, but this commission sure can. All we need is the consent of the governor to do that, and it is part of our responsibility to do outreach. And we are going to keep talking about it in our subcommittee. And, you know, is there a magic number of how many people in this state need to be part of our program? No, there's not a magic number, but the Oregon Pain Management Commission says 1 out of 5 people in this state suffer from some sort of chronic pain. So there is a pretty big number out there of Oregonians that can be in this program, and they need to be made aware of it. And that's part of our responsibility for patient access, is to make this awareness available to all these people. I know a lot of people that purchase cannabis over the counter for medical use, and they do it anonymously in these dispensaries. And I would say that I'm not going to pick any numbers, but there's a certain percentage of all those people that are coming in and buying as a consumer that are actually patients that purchase their cannabis to mitigate their symptoms anonymously. And we have to figure out how to get those people into our medical program so that they can take advantage, so they have a card that they can take advantage of discounted prices and the medical grade products.
I just have one little question about all these surveys. So the surveys of the OMMP providers and patients. So it sounds like we have capability to develop the surveys. Is it the deployment of the surveys that costs money? So is it the mailings and or do we have capacity? Like, I guess are there any barriers that require a budget request or something?
Well, we don't have the funding for it, but we have a program within public health that can administer the surveys. So
Yeah, I think to answer that question, we have technical expertise. We know how to do it. We can do sampling for it, et cetera. But in actually to spend the time to put it together, to figure out how to capture patients, how to implement, how to collect the data, how to analyze it, how to synthesize, et cetera. Yeah, and make sure that it's accurate and those kinds of things. So we have technical expertise. I mean, I know how to do this, Esther, you know how to do this, but you know, that's other duties as assigned. We're not actually going to do a robust process without more resources, which is back to my initial point. It's what is the barrier? Is the barrier knowledge? Is the barrier the resources? Is the barrier FTE? You know, what's the question?
Jeff?
Thank you, Madam Chair. I'm going to digress, but I have 2 questions. I want to ask Anthony one, just from my knowledge, back to this document that we received, that there's a discrepancy between the ratio. In your comments here, you said this was unworkable for most growers. OHA might propose a 3-to-1 ratio, and others are wanting a 15-to-1. Can you, just from my knowledge, tell me what the problem is there? And then I'm going to have a question on process for Shannon.
Well, the problem is, excuse me, the problem is that a 3-to-1 ratio, meaning you put 3 immature plants under 24 inches for every mature you have, it's just not going to work for a number of growers out there. It does not give them a large enough selection pool, to make an accurate selection for some of these more finicky strains. The work group came up with a number a lot bigger than 3-to-1, and I think we need to take that into consideration, and I think we need to err on the side of the growers rather than the agency.
Thank you. So if I'm understanding this, at a certain point, an immature plant does not turn into a mature plant because they're going to be
That's
Only so
correct.
many can move forward.
That's correct. And OLCC has unlimited number of plants below 24 inches as long as they don't exceed their immature canopy limit. And there's a lot of issues around this, but we've been having the same discussion for 3 years, and it really is time that it really kind of, as Giuliani would say, come to an end.
Okay, thank you. And a process question just for you, Shannon. I want to be clear on what our role and responsibility is as a commission. In the end of his letter, he says the commission should consider discussing overriding OHA's, whatever they recommend. And I'm wondering if that's, are we like the OLCC where rules are brought to us and we vote on rules, or are we just advisory and we're supposed to stick with the mandate that's laid out in 2198?
Yeah, Shannon O'Fallon. The Cannabis Commission is advisory, so it would not have the authority to sort of overrule OHA's decision on rules. And I guess the other thing that I just want to say that Anthony and I have a bit of a disagreement about whether or not there was consensus in this legislative work group. I would say that there was not. So I just want to put that out there.
I was just working from the meeting minutes, and you can dispute the meeting minutes if you like, but that's what we go by in research and doing papers and stuff. That's what the minutes reflect. You know, that's what they reflect.
So, I think we're digressing a little bit on this point. Both Anthony and I were on a rules advisory committee for this OMMP rulemaking. You know, as Shannon mentioned, this commission here exists to advise the agencies, and as somebody who has advised the agency for the last 8 years, I can tell you they don't always listen to your advice. I think if this commission wants to take a position on this particular issue, the thing to do would be to take that position during the public comment period for the rulemaking so that it can be considered by OMP on the record.
I would concur with that, absolutely. We need to, during the comment period, make a recommendation.
That would require consensus here, I guess. What is the deadline for making a comment here?
It's not out yet, so
Okay.
we'll be putting out the draft June 1st, and then that'll be posted to our website. I can send you a link when it
Great.
is posted to the website, and public comment is open for a specific period of time. So I'll send that out to everyone, and you can make a comment if you come up with that as a consensus decision.
Is that something that, yeah.
So just briefly, and I'm looking to our lawyer, and maybe I'm, there are a number of us who work for state agencies. So if a commission comes up with a recommendation, it probably is these members of the commission, because I think a number of us that work for the different agencies would have to say, recuse ourselves, and not that we're in opposition. But I don't think I'm, you know, so even though I formally sit on the commission. So just be careful, because even if the commission says something, it might be, well, at least 5 people in the commission, but these people have to abstain or recuse ourselves.
That's probably going to get us down to less than a quorum. So maybe we should just individually make recommendations as we feel so moved.
Yeah, and I think you could probably indicate that making the recommendation in my personal capacity as a commission member.
That probably makes more sense. Okay. So if you guys are still okay, I'd like to push on to the recommendations of research subcommittee. Does anybody need a bio break before we do that, or can I? Okay. Right, that's true. If you want to slip out and take your bio. Okay, so why don't I move on? So there is a draft of, a first draft of the legislative proposal for research in your meeting materials. It's called the draft legislative proposal for research, and I'll just go through and then we'll love your comments. So there's a little bit of background about the need for research that I'm guessing we're all on the same page about. The goals of this, basically what we proposed was that the state of Oregon establish a center, a cannabis research center devoted to advancing science related to the health effects of cannabis cannabis consumption. The goals are laid out in part 2. The CRC, as I call it, would develop lines of inquiry within 3 general priority areas. Those are the ones outlined in House Bill 2198. And then within those broad areas, we outlined a number of priority topics. And those were well outlined in the report of the task force established by Senate Bill 844. So they follow along the 5 general areas of research basic plant and agricultural research, public health research, observational studies related to the medical benefits of cannabis, preclinical research, and clinical research. The way that we conceived the structure was that this would be a collaboration across academic institutions and in conjunction with the Oregon Health Authority. Thought that such a research center would probably best house at Oregon Health and Science University because it is focused on the effects, the health effects on patients. But we did think there could be potential co-leadership by OHSU and Oregon State University. And then we thought this could be a nice place to coordinate the research by a large number of member investigators who have established experience in cannabis research that's highly relevant to public health and medical care. The funding section is the most sketchy. This, I would say, you just sort of feel free to be aspirational when you're first putting these things together. But I say that these aren't numbers that are out of the sky. We received input from established cannabis research centers, including the one based at University of California in San Diego, and also from the Public Health Department of Colorado, which has administered 3 separate grant programs, all between $9 and $10 million. The Cannabis Research Center that's been around for about 20 years at UCSD was also established with initial funds of about $10 million. And it just seems like that is the magic number, kind of robust initial research program that is able to support itself administratively and create enough pilot research that it can then use that pilot research to be competitive for external grants. There are plenty of cannabis research centers that have risen and failed quickly for a number of reasons. I think most of it is like a poor sustainability plan and insufficient funding so that it was vulnerable to political forces that discourage research in this area. So we're still receiving input from cannabis research centers around the program, but this was kind of like the initial best guess for what would create a viable program that could really do the kind of cutting-edge research that Oregon would like to do to make a difference for our patients. I think, we talked, I attended Anthony's subcommittee, and we talked a lot about the challenges of funding this, but I think what we agreed upon was that having funds from the OMP program that went directly to something that benefited patients like medical research felt a lot better than having funds that went to things unrelated to the program or to patients. So it just seems like this would be a more palatable option. Where exactly those funds come from is open for discussion, but this is one that is going to require a clear financial task. And that can be hard. I think was probably the death of the last round of recommendations in this route. I feel like you're reaching for your microphone, Jesse.
I'm waiting patiently, so it's not to interrupt.
Okay, should I continue or do you want to insert? Okay. We had a lot of specific thoughts about grant administrations, maybe more detail than needed, but we just thought we'd lay it out here. Again, this is also based on the experience of other states in establishing a research program, and what we thought made most sense and could start small and be scaled up if the research center initially supported a number of both internal and external grants, which would be awarded through a rigorous competitive peer review process similar to an NIH grant program with key input from the Oregon Health Authority. That way, we could make sure that the research that we do is both high priority from a public health and medical perspective, also very focused on the health and safety specifically of Oregonians, and that it would really support best practices and policies for the OMP. Every state has kind of handled it different, like who those grants go to, who's eligible for those grants, do they have to go to investigators in Oregon? There's kind of like a whole side note on why it might make sense to sometimes award those grants to people outside the state of Oregon if they bring in necessary expertise or allow us to build up a critical mass of patients who have rare conditions, and it would be impossible to get a good sample size simply by restricting research within our state. So unfortunately, there are people that have gone before us who have kind of learned the hard way about how to administer those grants, and we're trying to take cues from them. I think oversight will be an important component of such a center. There are a lot of people who wish to contribute to medical marijuana research, including people from the industry and even just private people. And I think there should be ways to receive those funds, but also ensure that the research that we do is free from undue influence that would compromise the validity of the findings. There are many, many functions of such a center, and I have to say, although these are kind of thrown into other, just like long laundry list in part 6, I would say some of these things overlap with education and also actually with every other subcommittee, because what we're proposing is that this center could look really rigorously at any innovations proposed by the other subcommittees and give us a sense on a policy level as to whether we're taking the right direction, if the things that we're doing, say we implement statewide training, is that training effective? How is it actually changing the lives of our patients? Is it, or should we head in another direction? Same thing for product integrity. There's lots of questions and diversion, and certainly for patient access. Are the interventions we're doing actually representing the needs of patients in Oregon? Are they effective? How are they optimized? Everything that we do is subject to scrutiny. Wouldn't it be nice if we had a body of researchers with expertise in this area? I think also, as we discussed in our research subcommittee a ton, Katrina, we talked a lot about the inherent challenges of this kind of research, particularly given its Schedule I designation federally. We had Dr. Colin Roberts here on Friday talking about how he's navigated some of those. It was super interesting. Remains a challenge, but he was a good model. He's a pediatric neurologist at OHSU who is studying cannabis in his young patients with epilepsy through industry-funded research projects, and he's gotten his Schedule I license and navigated some of these things that are really tough. And there are clearly a lot of common lessons learned that if you had a center, you can simply educate all of your researchers in a pretty efficient way and make them all much more skilled in navigating those barriers so that we can get really to the kind of clinical bedside research that will make a huge difference in the way that we're able to administer medical care. So anyway, I can let you read all that at your leisure, but we just thought that such a center would be, it's timely, it's actually beyond time for such a center, and I think it could serve a lot of functions for the state. So I'm really open to feedback.
Yeah, so just to add a little bit, one of the things that this subcommittee that we did look at is, of course, we were talking about Senate Bill 844, which did a pretty rigorous look at what data were available, and there's since been the National Academy of Sciences had put together the, I can't remember what it's called, but the medical aspects of cannabis and cannabinoids or whatever. And so less about those details. Right, and really instead to focus less on the content and more on, so what structure would we need? So we had done a little bit of that in 844, but that was really kind of the focus. The focus of the group was this administrative. So we didn't want to rehash the details of what's known, what's not, and what are the areas of focus, etc. But really, the reason this hasn't gotten off the ground is we don't have an administrative structure, whether it's an institute or kind of universities or grant funds or whatever, to launch this thing. So that's really the barrier.
Totally, and when 844's task force came out with its recommendations, they actually recommended a freestanding institute, and I think that made sense for a lot of reasons. It can kind of help you navigate the chronic fears that academic institutions have about whether or not they can bring this research into their fold but still be eligible for federal grants, especially with like the ups and downs of political cycles. But I think part of us wanting to make this more feasible was actually housing this at an academic institution this time, because the infrastructure is there, the investigators are there. It's actually a much less ambitious ask this time, and we're really trying to, I think we're really trying to make this as feasible and doable as possible. So hopefully we can get some energy and excitement around this type of proposal.
Chair. I think this is a great proposal, although I do have some concerns over the funding. Funding is, of course, a challenge. My particular concern is the proposal that this be funded out of OMFP fees, we just had a pretty robust discussion on what's the right number of patients to be in the medical system. Those are the patients that generate the fees. I think there's going to be a lot of diversity of opinion on this commission about what the right number of patients are. I would posit that if we accomplish our objective of achieving regulatory oversight, the number of patients could fall dramatically as a result. So, keeping that in mind, it seems like a particularly volatile funding source.
Well, I'm very happy to receive funds from the recreational program, but I think I was told early on that that would be an unwelcome suggestion as well, so I'm open to any suggestion.
Well, the way the recreational program works is we don't have any funds. We're fee funded off of our license fees, and those go 100% to our operations. That leaves you with, of course, the tax receipts, and when you're asking to be funded out of the tax receipts, you need to kind of lay it into the mix and fight it out with everyone else who would like to be funded out of the tax receipts.
You're going to need hip waders.
Yeah, no, that is true, although I will say that other states have had a clear designation, from the tax receipts for the research part that has been kind of standard. California, in their new program, has just designated 2 large pots of money from the taxes raised from recreational marijuana. One goes to sustaining that UCSD program. The other is kind of undifferentiated. It's up again, it's always $10 million. I don't know why that's the magic number, but it's always that.
I just want to comment that I like this proposal. I think it's probably the most fully baked proposal that we have today. And then my just recommendation is that we probably work on the structure a little bit, on eliciting the structure a little bit more to put into the report. And then I guess for funding, I don't know. I don't have any experience lobbying in front of legislative bodies, but I would say that we just put the money that it would cost to operate the center, or how much it would cost to start it up, and we leave it up to the legislative body to debate on how they would fund it. I mean, maybe we do put a recommendation that we use, the tax money to fund it, but leave it as general as possible and let them kind of debate it.
Yes, I was going to say exactly that too, that the amount that we would need is different than where the legislature knows full well where money in the state comes from. I mean, it comes from general fund, right? So taxes, property, income, it comes from fees, other funds, it comes from grants, etc. So I'm not sure we need to tell them which pot of money. So other than the amount that we need, because again, back to the hip waders, spending a lot of time discussing, you could fund it out of here versus there, and then suddenly, how does this rank compared to education for kids or whatever, whoever else might need funding out of that? I don't think we want to go there. I think we want to talk about how much we need, what the barriers, etc., and not where the funds would come from.
That's easier.
Hey, this is Pat. I'm trying to follow along. Could you tell me which attachment on Shan's email that we're reviewing?
Yes, it's called the Draft Legislative Proposal for Research.
And there were 3 emails.
Oh, there were 3 emails.
So you might not be looking at the right one. It came in as it's in the first email.
It was in one of the several emails you received today.
Thank you.
Thank you.
While it may not be necessary to, advise on where the money could come from, I'm still in favor of recommending that it might come from tax receipts from rec. It makes sense. It feels good. It's what's right. And so I think coming from our commission, I would want to be clear that we do have sort of an expectation that some of that money goes into research. Whether they, take our advice or not and implement that, that's up to them. But I think I would feel good about our work if we made it clear where we would like to see some of that money coming from.
And the appealing thing about that is that there's precedent in other states, so it doesn't feel like as out of the blue. So
If they can skim the tax revenue for an illegal marijuana enforcement fund, they certainly should be able to skim it a bit for research. So, does the chair think that there's going to be any particular, we're going to meet with any particular barriers, vesting it in one of the schools with respect to federal funding? What's the plan there?
So we had on the call at our last subcommittee, Peter Bark-Lesby, who's the Vice President of Research and Development at OHSU. He's relatively new in the role, but we brought him in specifically to comment on whether such a center would be feasible given the traditional concerns about its impact on federal funding. And then Dr. Roberts was also here to just talk about whether that he sort of got the sense that there was any institutional barrier because of that reason. So both of them expressed a lot of enthusiasm for housing such a center there, and felt that the time feels right, that institutionally it would be aligned with its bigger goals, and that nobody wants to halt research in this area or balk from that. I had Cindy Sagers, who's in a similar position at OSU, was not able to join us, but I did have a brief conversation with her explaining why we wanted her here. The quick answer I got was that they would both be excited about, sort of maybe co-directing such a center, but also that there would be about, 75 conversations that would need to happen successfully in order for them to overcome some of the traditional fears about this kind of research and its impact on their federal funding, which is obviously critically important to them right now. They don't want to put any of it in jeopardy. So there's kind of a range, but definitely I felt a lot of openness and excitement about it. So that's why I was a little bit vague with the structure. Is actually I just wanted to make sure that we had institutional buy-in and a comment about feasibility before we were too specific about how it might be structured. So there's a lot of sort of potential might, that sort of language. Yes, I think we're a little overdue for a break. So 5-minute break and we'll come back and reconvene. Thank you. Did you help document and have any comments?
I did find it, and I'm almost done. I like the first page, and I'm on the second.
Perfect. So when we come back from break, we can take your comments if you have.
I'm sorry?
I was just going to say when we come back from break, we can take your comments if you have.
Very good. Thank you.
See you all soon for the second part.
Well, nothing profound, but thank you for letting me know there was a second and 30 minutes this morning. I would just say that I think it's a thoughtful piece and it's well written. I like the fact that we create the center. I'm not sure about the dollar issues. Is 10 million the right number? I don't know. Or 3 years? I'm not sure. I'm not convinced that that's our decision. And a little micromanagement part under the goals on item C. Further down it talks about having a balanced center in the oversight section, but then there are other areas that talk about the benefits. And I think it's probably better to say something like medical effects and adverse effects, something like that. So we're not appearing to be biased in one direction or the other, but that's sort of a wordsmithing issue. That's one of the goals, item C, in the observational studies area. That's it. Thank you.
Thank you. That's really helpful and true.
I agree with that.
I totally agree. Yeah, I missed that, but it's so obvious when you point it out. That's a change that needs to happen. Okay, so why don't we move on? I'm actually going to skip over to the budget just because I think we're so eager to hear that from Carol. So why don't I turn that over to you?
Thank you, Madam Chair. You all should have received our biennial budget. It's in the packet right out here. Yeah, that's it. That's it. Beautiful document. Everybody have it? Okay. Right after the deficit on the second page. Yeah. So the way our budgets work is we do have a biennial budget. It's at the beginning of the biennium you have the cash rollover that becomes your beginning balance, and then you create projections based on data, historical data, how many patients, how many patients pay full price, how many pay at a reduced fee, your growers, and very, historically we had dispensary processor revenue that actually added to the program. And those items become your budget. Then each month, as you get the actuals that come in, so we run, the budget runs from 7/1 of 17 through 6/30 of 19. That's the way the budget system works. So then every month, as the actuals come in, we reforecast with the actuals for the month plus the reforecasted projection through the first year, and then the second year is still a total forecast. So this projection is actuals through March, so you will have 3 more months that are, so 3 months in the first years of the biennium of projections, but actuals through March. We have seen a steady decrease, as everybody has been talking about, in our patient volume, in our application volume going down. We've seen, just data-wise, more of the revenue going down in the full price, the $200 payment, and the increase in the discounted prices. So I would say probably in December of last year, we started to see the first time in history for us where our reduced price fees was 51% and 49% for full price. So we're definitely seeing that trend. Again, a great survey to find out why. We all have questions that we would like to have answered. Is that partially people can have cannabis now legally? Is that part of it? Is it access or is it costs? All of those things. So, so that's a little bit on how this is broken out. So if you'll see our general fund, we receive $250,000 a biennium, and that is new. That started in this, it was passed in the 2017 legislative session when they created the commission. And that was to pay for half of Shannon, and then to pay for half of an OPA 3 to assist with the commission. So that's what that dollar amount is. And then the rest of our money is all other fund. As Katrina was alluding to earlier, the different funding sources that the state has. You either have general fund, you have other fund, or you have federal funds. We are not a federally funded program, we're an other fund program. So the basis of our revenue is all through fees, which is considered another fund. In the patient revenue, you'll see that our projections in 18 are much higher than in 19. And again, it's because we've taken the same forecast of that reduction. We have no idea. I mean, you're predicting the future, obviously, and it's very difficult. You're looking at the trends and you're looking at what has been happening. And at one point, we thought the trend would be to stabilize. And by the time we started this biennium, that we would be pretty well stable. That hasn't happened. So, the program is in a state of flux, as we're all aware. So our FY19 forecast for the revenue for patients is taking into account that the revenue, the revenue for the fees, reduced price fees is going up, so that means your revenue is going to go down as well. And then also looking at taking a reduction each month on that too. Grower revenue has a very steep decline in 19, and again, it's taken into account the growers that are either seem to be leaving the system, or a majority of our growers are patients that grow for themselves, and more people are moving to that model more. And that does not have a grow site fee if they're growing at their own residence and such. So it takes into account that aspect that revenue is going down. When you see the metric revenue, that's a pass-through fee. That was projected before all of the changes that happened in 1544, and at that point we thought we would have about 3,880, I believe, is the number that we thought would need to be using the cannabis tracking system, and that at that point was a price on every grower. Initially, we thought every grower had to pay that price, and we actually got the fee at the grow site level, so it reduced the cost for our growers by having it at the grow site. So whatever that dollar amount is, 100% of that is transferred over to OLCC, and those funds are used to pay for metric. Neither OLCC nor OHA has an administrative cost on that. That is strictly to utilize the metric system. So you'll see that there's no revenue in, and then down below you'll see revenue transfer. So it's considered a pass-through fee. The revenue for the dispensaries and processors, we have negative. Basically, most of our dispensary revenue and processing revenue, most of them have moved over to OLCC. So we've had instances where we've had to reimburse applications, and so you'll see a negative because of that. Do you have any questions on revenue? Okay. So next part's, so it's less allocated cost to OHA and PhD. Those are administrative costs of being in a state agency. It can include rent, facilities, telephone, computer access. It's all of your shared services for both OHA and OLCC. Every grant in the state pays their portion of those costs, whether you're federal or other fund, or federal or other fund pays those costs. So those are the two costs there, and then you'll see the metric revenue transfer out, so the money going back out. The next line is the state support for public health transfers out. That is a legislative action. This last biennium, they reduced it from in the biennium before, we supported a higher number than that. It was about 18 million that went to fund other programs. These are legislative decisions as to programs that they felt needed to be funded, and utilized the marijuana funds for that. It was reduced this biennium, so we have 7.1 or 7.2 that is funding one program, which is state support for public health. That gives us our net revenue, and obviously for 19 it is much reduced revenue because the beginning balance is included in the 18s. So yes, that's one reason why you see such a difference in funds. Personal services is what it costs to run the program. We have filled positions. We have 44 filled positions. We actually have 53 positions in the program, and have chosen not to fill some of these to reduce costs as much as possible. We have had some legislative actions that have reduced, or will be reducing, some of our positions in the upcoming months, actually. In the legislative session ending 7/1/17, there were 16 positions removed from our budget. It was the compliance unit and the majority of the analysis unit, other than a research analyst and an economist. We worked then with the legislature. They made that decision based on the thought that the majority of growers would be moving over to OLCC. And so when you do a revenue reduction, you have to balance it within the budget. So we did make that reduction. And then we've requested additional staff back and have gotten permission to fill some of those positions, and have gotten permission to work towards filling some of the compliance staff in a limited duration position for till the end of the biennium. That's not finalized yet, but we are working on that. So that's the personal services part. The rest, the OAS direct charges, that's the cost to have staff that assist us with maintaining our databases and data systems, and all of the, all the changes that are needed. Each legislative session that we have done, or created the patient online and created the grower compliance and the processing side, those staff that are direct charge to us. We, at this point, will end with approximately $3 million. But, as you go then and start the biennium again, you're looking at almost a $2.8 million less at the beginning balance. So as you continue throughout the next biennium, the revenue the balance will end up much less, most likely not positive. Questions?
What happens between the projected cash balance at the end of fiscal year 18 and the beginning fund balance in fiscal 19?
Can you use the microphone?
Oh, I'm so sorry.
So I'm just missing some math here. So the projected cash balance at the end of fiscal year 18 is 4.5 million, and then the beginning fund balance for fiscal year 19 is 3.1.
Interesting, she has that number wrong. So I will have to find out because that's a huge difference. Yeah. I will have to let you know that. Yeah.
Jeff Coons for the record. So I caught that you said you lost 16 compliance officers for this biennium.
No, 16 positions.
How many compliance officers and how many are you asking for to come back that are compliance officers?
So the compliance, we lost the whole program initially for the compliance staff, which was the manager and 5 compliance specialists and the other compliance specialists that go with that. And then coming back, we were authorized to have 3 compliance specialists.
Carol, do we have any idea how many growers, OMNP growers, actually moved to OLCC?
Not off the top of my head, but we can find out for you.
Okay, thank you, because there has been a lot of projections based on all these growers moving to OLCC, but I'm not finding that to be the case. A lot of growers stayed, most of the growers stayed with OMNP from what I've been able to pull, looking at the statistics. I think at one point you had mentioned that there was about almost 600 that had actually moved inventory over from OMP to OHA. I'm sorry, OHA to OLCC.
Yeah, I don't have the number off the top of my head, so I'll get that for you.
Okay.
And can we get the numbers or the breakdown of which discounted prices people are using? And we have several buckets. It'd be good to see which areas are the
I
ones that are
will,
growing.
yeah, we have I'll get the statistical snapshot for you guys that has the numbers, the breakdown.
Down on use fees.
Yeah, so she wants to know what percentage is OHP, what percentage is the Fed, which percentage is the SNAP.
Well, just a quick look at the April statistics. 49% qualify, no, 49%. 49%. 49%. You're off.
You're still off. There we go.
49% no reduced fee eligibility, 7% for SNAP, 24% for OHP, 6% for SSI, and 14% for FES.
Yeah, and then we'll just need to be able to compare that to other years to see which buckets are growing faster than others?
Well, in 2012, there were 60%. In 2012, there were 60% not eligible, 32 on SNAP, 2% OHP, 6% SSI, and nothing for vets because they didn't have a reduced fee then.
That's one population that has increased a lot with the reduced fee for vets, and then allowing for a vet that's 100% disabled to not, after they've gone to the doctor once, to not have to go back to the physician. We've seen that population steady increase.
And it's like the fourth largest category that signed up. It's about 5,400 people or something like that.
How does this make you feel in terms of, I mean, part of your patient access subcommittee was addressing, you know, are there expanded ways people could qualify for reduced fees? I'm just looking at this budget, make you feel any different?
No, I'm still very nervous about it all. And being able to keep funding the program off of the fees is going to be getting harder and harder unless we start doing ramping up outreach and expanding the patient population.
So, someone who also works with a fee-funded program, there are 2 other ways to deal with this shortage: cut program and raise fees.
It's funny how we haven't really found a third dimension to that yet. So is there any of this that, I guess, what more do we need to know so that we can advocate for the sustainability of this program? Because this is looking pretty grim to me. Or how do we, you know, I mean, we hope that some of the things that we're talking about will kick in as far as outreach and just like public awareness, strengthening the program, while still increasing access to patients. But is there more information we need, or just simply looking at this, does this make any of you feel like there's something concrete we need to include in our legislative recommendations to increase the financial health of this program?
Yeah, I think we need to recommend for taxes to be reallocated. I do. I mean, not that they're going to acquiesce to that advice, but why isn't that one of the line items?
So I actually, I don't entirely agree. It's back to the comment I made earlier. I think it's really important to point it out. This commission is supposed to be making comments or report to the legislature, and I do think the financial viability, or whatever word you want to, that's important for them to know. But again, back to what I said earlier, they know where the money is, and so we don't necessarily have to say, therefore you need to take money from retail, or therefore you need to not allocate money, such and so on. But I do think it's important to, in this report, say that one of the things, again, a barrier to a viable medical marijuana program is that cardholders are going down, funding is going down, and you either cut program, increase, revenue, funding from somewhere. So again, unless, and we have a little discussion, but especially those of us working for the state agency, if the governor's office wants to strongly say this would be the source of funding, etc., we work for the governor, and those of us working for state agencies could get behind that. But otherwise, I think it's important to point out what the barrier is, and I don't know that it's value added to say, and therefore we think you ought to allocate money from.
Yeah, and I wasn't thinking in that sense, more like everything that we've mentioned so far is a potential suggestion is at cost. Do you know what I mean? So it is, I guess it's a funny report if we say, we would like these 5 programs, they will all cost this amount of money, please find it for us, and by the way, the entire program looks like it's not, it's headed in a really difficult financials. I'm just wondering if there's any way to sort of balance our proposal so that it looks like that we are
Surviving but still need money.
well, I don't know. I don't know how to do that. I don't know how to make recommendations that are. Or is that, do we just say, it's a tough sell, we leave it to you to figure those things out, or are there recommendations we can make that would suggest potential efficiencies?
Yeah, I mean, maybe the report, in part, is that the program is at risk. I mean, in the report, it's, the medical marijuana program, OMMP, but here are a number of things, it could even start off, the program is at risk because fewer cardholders and blah, blah, blah. Now here in our report to you, there are different aspects you asked us to report on, and we're telling you about research, and we're telling you about, patient data, et cetera. But the program, the funding is going down, and the program may not be viable financially.
That's a message that needs to go to them tomorrow,
So-
frankly. And I know budgets and bienniums and all that sort of stuff are at play here, but this program is in serious risk of caving in on itself. We gotta figure out how to stop it, because we got 45,000 patients out there that need this program. If we don't come up with a solution, if we don't come up with some kind of path forward on this, this report in 2019 may be too late.
I don't think we're in that dire of a situation, but I do think that long-term, we need to definitely be looking at it. We're not in a negative at the end of this biennium, but I do think we need to be working towards that solution.
Well, I'm also concerned because of these 20 or these 2,000 some grow sites that are supposed to create grow site administrators are shying away from it due to the cost. We may be lucky if we get even half of those people to create a grow site administrator and come into the OLCC tracking, remaining with OHA, but come into the OLCC tracking. That's going to devastate the program, and we're going to know those numbers within the next 60 days.
Are you meaning if they don't follow through and actually begin tracking? And yes.
Yeah, if they cut back to 12 plants, or they bail from the program completely, which I've heard a number of longtime patient providers are doing, 2019 is going to be too late for this program.
So,
I mean, I see the numbers, 2019 is the number we really go into the red on, but if we don't get relief from some of these costs, these growers are just not going to participate. They're going to drop out of the program except for growing 6 or 12 plants, and there's not going to be enough money to fund the program. And I think that's coming sooner rather than later. I get it, stress it enough. This program is in serious trouble, even though it looks like we got $4.5 million this year, but next year's not looking so good. So between now and then, we got to come up with a solution.
Anthony, I want to bring this back a little bit to the statute. We're tasked with determining a possible framework for future governance, proper oversight, and regulation. So all this talk about budget assumes that budgeting at current levels is the correct framework. And if you make that assumption, that the program as it stands today is the correct size and scope of the program, then yes, we have a budget problem. But if we come up with a different determination about the size and scope of the program, the budget problem may look a lot different.
That kind of leads into our next agenda item, if you feel comfortable. Do you all feel comfortable moving on from the budget? That was super helpful information. Thank you, Carol. So I'm going back to the thing that was originally before that. So I had put on this a discussion of the structure of the OMMP, and out of respect for all of your time and also to still save room for public comment, I actually suggest that we just take a moment to, there's a kind of this report that's here that should be next in your packet. It has this beautiful green cover. So I want you all to know that it's here. This is kind of a summary for how the medical marijuana program is structured in other states across the nation, including those with and without recreational programs, whether it's under a single agency or multiple agencies. I actually would move that we defer a full review of this and conversation until the next meeting, so we can really give it its due. I would suggest that we, to the extent that the size and the scope of the program, as Jesse pointed out, relates to this discussion of the framework of the program, that we include that in that discussion. And that also all of you take a little bit of time to read this through. And if there's additional information that would be helpful before that discussion, to let Carol know, so that we have the resources, the information, the background to have a really robust conversation. Does that sound okay? I feel like we just kind of barely get into that. Okay, so that'll be, let's just try to make room for it in our next meeting. Thank you so much, and I love this report. So let's move on to just a quick revisiting of the listening tour, just because that has always come up. It's never quite been the right time, but I just wondered, maybe in the subcommittee meetings or in other discussion we've had, has anybody had further thoughts about whether now would be the time to schedule a listening tour, if that would be helpful for any of our objectives? I know we have a really packed schedule for the rest of the summer with our subcommittee meetings and our commission meetings and our agenda items. I mean, it is, without adding anything else, I think it's a really ambitious schedule for the rest of the summer. But at the same time, the listening tour came up again and again as something that we all felt like was important at some point. I would be okay if, and I guess my personal preference would be to just really focus on getting to where we need to go for September, because this summer, as I march it through all our meetings, it's going to go by really fast, and we still have a lot of work to do to refine our thoughts into our report and legislative proposal for the fall. I'm already feeling kind of nervous about it. And then in the fall, we can sort of turn back to the list when our time opens up, and we don't have that the same like sort of punishing subcommittee schedule, that we can turn back to listening and really spend our time thinking about it, what we want to get out of it, and some meetings around the state. But I would love to know that that's consensus in the group.
I would think the fall would be the appropriate time to do it. And I would suggest that we incorporate at least one of our commission meetings as part of it. So if we're going to go to Southern Oregon, let's just have a meeting down there and listen to the people. So maybe rather than trying to do boom, boom, boom around the state, we do boom, space, boom, space, boom. And get it all done by the end of the year, and then that way we can report back to the legislature on some of the stuff, some of the feedback we've heard.
I love that. I think we should actually call it the boom, space, boom, space, boom. Listening tour. Okay. All right. I think we're agreed on that. So why don't we end? If there are no other comments from?
I just had one other question with regard to just historically with the OMMP since 1998 or inception. Is there some document that you can show us how the program grew and what funding looked like and at its peak with patients, and then where we're at today? And because I mean the answer is going to lie somewhere in the middle there with what does your staff look like, what are they tasked with, what's been shifted to OLCC, what recommendations might we make about the framework. So I just, whatever you can provide us, it's probably on your website, but if you could bring something, it'd help me.
So are you thinking revenue, staffing, the whole, get the whole? I will have to run that up. I have to get approval to be able to put any of this out. So yeah, certainly can.
I'm thinking revenue, staffing, and the number of patients, because to me, at some point in Oregon, we didn't have 47,000 patients, and the program had adequate funding and kept growing. Now we're going backwards, and we hear the sky is falling, and I don't know that it's falling or it isn't falling. So
just a very quick comment. I don't have the answer, but of course you're absolutely right. It grew, and I think its peak was 75,000 patients.
78044.
Thank you, 78. 044. But as I alluded to a little while ago, it's very hard for us to talk about because initially there was a program where people were allowed to have growers and caregivers, but there were no dispensaries. Then there were dispensaries, so the whole process switched. And so some of the things, for example, initially with the card program, we didn't have any compliance officers because there was nowhere to go check. So it's very hard to look at exactly that issue because so much has changed. It isn't just the number of patients that have changed, but what the program encompassed. And then, of course, there became retail sales, and people moved over, and then there was a whole laboratory. So every legislative session, something else got added, which meant that staff got added to do things. So even it might be right now, and I don't know this for sure, but the same number of staff for the current program, even though they're half the number of cardholders, because those staff need to do a number of things that were not initially when we only had a card program and didn't, and caregivers and growers, but we didn't have any sales of the product.
Another comment I would make is that as we brought growers above board with our dispensary program, the OHA dispensary program, more and more growers were adding more and more patients, and they were taking care of all the bills for the patients and providing them £1.5 pounds of cannabis every year. But that number 78044 is really misleading, because a lot of these growers add more patients to get more product to go into market. And then when some of these growers jumped to OLCC, it left those patients hanging, and then they had to absorb all the costs. Cost of card, cost of the doctor's office, cost of grow site registration fees if they became their own grower at somebody else's address. So just looking at the numbers as a whole be somewhat deceiving, because that was a huge chunk of growers that they added over the course of about 15 months. And that's why we're seeing such a dramatic drop in a sense, because one, the program has just gotten really expensive for just a patient that it doesn't get any reduced fees and whose primary care physician won't sign off APS form. But when these growers that were paying all the fees abandoned their patients, these patients were left holding the bag with no resources to pay for the doctor's fee or the card fee or anything else, and so they just stepped away from the program. So that's part of the reason. Cost is the other part, and then of course the ability of the growers to meet patient needs with the limited number of plants that they now are restricted to.
So Anthony, if growers were paying patients card fees and doctor fees in the past, why were they doing that? What's the incentive?
Bottom line, they wanted patients. Patients didn't know where to get growers, so some of the clinics had patient or growers that they could put patients with, and so that was part of the process, and it really overinflated those numbers. Now some of the growers are still paying all those fees for their patients, but it's getting tougher and tougher. If you've got a 16-patient grow, if you've got an 8-patient grow site, 48 plants, that's $1,600 in grow site registration fees right there. When you add the $480 metric user fee, you add the cost of purchasing a certified state scale, and then all the other production costs that go along with it, these growers are rapidly becoming less and less incentivized to grow for patients. And the two prongs of this program were that patients could grow their own medicine, and if you couldn't, you could designate somebody else to do it. And the steps the state has taken over the last 3 years has almost decimated that grower community, and led us to the situation we're in right now, where patients can't find growers anymore. That number has more than doubled over the last couple of years. And the growers are unwilling to take on more patients because they have to pay more money. So some of the growers said to their patients, happy to keep growing for you. You have to designate yourself as your own grower at this grow site. So you have to pay the grow site registration fee and not me. So all of these things have cascaded and left us where we're at right now with 45,000 patients. And that, I would add that that's probably a truer number of those Oregonians that are willing to opt into the program to get tax-free and medical-grade product, but it is way short of the number of Oregonians that could actually qualify for this program, especially since we've added PTSD and pervasive and degenerative neurological conditions.
And just to add a little to that, the 30,000, or maybe it's 33,044, but that are no longer on the medical program, they might still be using cannabis, they're just buying it retail. And again, the dollars and cents, depending on how much you use, looking at the cost of the card and the cost of all of these other things, it might be, and if you're not using that amount that is worth the tax deduction, it might be cheaper for you to be getting your medicine at, retail, even though you're paying the tax for it. You're not paying. So again, back, you asked a simple question that is incredibly, on the face of it, it seems simple. But, so that's my guess, is not that those 33,000 stopped using cannabis, but that it was cheaper for them.
Some of them are true.
Cheaper, we all do that, right? You look at, the medicines that you buy, and you're like, well, overall, the cost would be cheaper here, and I'm getting essentially the same medicine that I was before, so.
But they're
Some
not getting
patients
the same
are-
medicine,
yeah.
and the prices are out of reach for most patients. So we have to address those issues.
I'll say a bunch of my Southern Oregon patients are no longer, buying cannabis. They're not going to the retail shops down there and getting it. A lot of them have gone back on their prescription opiates, unfortunately. And they still come in to see me because, well, they want to talk to me about using the cannabis, the little bit they are growing for themselves. But a lot of patients are just giving up.
I was just wondering, Carol, I think this is kind of part of the budget projections, but is it easy to get a little bit more fine-tuned data on what's happening with registrants? I guess I know it's going down overall, but I would love to see the rate of change, the slope of the change, and whether it's leveling out at all, like whether it's quarter to quarter or month by month, and whether we could see that. And then also the breakdown by type of discount program, just to see where the.
Yeah, we can get that.
That would be awesome. Just kind of nice to know how much to panic.
So the program puts out a quarterly statistical snapshot every quarter. They're all online. Most recent one's April. And it gives you that breakdown. So I would encourage people to take a look at that first. If they don't get the information that they want, then maybe Carol can get her staff to get a little more specific on that
We
data.
have it in other reports. I think the trend report is not, but that's a different report that might show that information. No
As far as the
numbers.
curve.
Yeah,
Okay.
I mean, it definitely,
A
either
graphic
way you're going to see
illustration.
it. It's just with the trend report shows it a little bit more by the,
Okay, right?
yeah.
Okay,
Okay.
yeah.
We can look, or there links you can share.
Yeah. And I think, as Anthony was saying, the numbers were very inflated. So again, it is a difficult, the high number that we have was an inflated number. Where that reality is, not too sure. We could maybe look at just since legalization. The program, as Katrina had said, before that was a patient-centric program with just growers. Upon 2015 is when the compliance unit, the analysis unit, so the processors dispensaries were brought into our area. So maybe that analysis might give you just even since legalization a difference. It might be more apples to apples.
I'd also just add quickly that, just like to add quickly that just because the numbers are going down does not mean less people are using cannabis medically. In fact, exactly the opposite is true. They're staying away from the program. They want some anonymity, and unfortunately, they're paying the price for it for products in the stores. If you buy a gram of RSO, for instance, comes in a 1 gram syringe, 1 milliliter syringe, $50 to $60. You're using one of those a week. It's going to put it out of reach for you if you're on fixed income or low income. So a lot of patients are going back to their old sources for product, and it's not a good thing. We need to make sure that our patients in this state are aware that they can grow it for themselves, and if they can't, they can designate somebody else. And there's a lot of people in this state that can't grow cannabis because their lease says they can't, or they're in government housing, or they're just physically incapable. So the really important part of this program is that leg that if you can't do it for yourself, you can designate somebody else to do it for you. And while I want to see the patient number grow, I think we can do that without exploding the number of growers that we have in the system. So we really have to stay focused that people, Oregonians that are using cannabis as medicine is not a declining number, only participation in the program. We need to fix that.
Okay, let's move on to public comment. Is there anybody calling in who wants to comment? I always feel like I neglected that opportunity. All right, otherwise I'll move on to the check-in list in order. And I'm going to hold you all to a strict 3 minutes just so we can get through everything on the list. So I'll start with Mike Rothman.
Afternoon. Mike Rothman, for the record, Cannabis nurse and advocate. Many changes, just like we heard Carol describe, have happened since legalization in only 2 years. It seems like 10. People say cannabis years are like dog years, so they are. Right now, retail is the main focus, has been the main focus with OLCC. The OMP has been, like Anthony's described, pretty much decimated. I think there was an expectation in the retail industry, at least one trade group, OCBC, admitted early last year they made a mistake in lobbying that they were doing. Okay, so that fact itself, when Don Morris said that in public, or at least at the meeting, told me that we were on the wrong track over a year ago. And so my concern is there's 2 major needs for funding right now. One is research at the top of the list because, and I'm not talking about the full center, but just get some money, get some staff out there, at least staff, to start working on this structure in a very aggressive manner, because we've lost 2 years essentially in the state. That's what really, really upsets me. And the other thing is testing. I think what Jesse said is really important, that we have a robust quality assurance program for testing. And I know at least one lab that's very, very credible in the state that could do that as a contract lab. And I think that's what we ought to move toward immediately, getting some money for that. We've gone on too long. We don't test for metals, and there's other quality assurance issues I'm concerned for medical patients. So that's a real high priority. Now, as far as the medical program goes, that should be different from legal adult use, because adult use is a consumer product. Medicine is not, and therefore the ways they're managed in terms of the product safety labeling, all that should be done differently. It's a higher standard. I've heard the use of the word grade, which is significant because when I was testifying in the legislature, grade means purity and quality. It does not mean strength. And medical grade in the state has been misused to mean strength, and that needs to be changed immediately. The other thing is that patient access is critical. I agree with Dr. Rachel that there's a lot of patients fending for themselves, partly because of costs. If they're on fixed income, on the Oregon Health Plan, etc., they don't have a choice. And the policies right now are very prohibitive because they're mixing, not mixing. You can only go one of the other opioids or cannabis. Therefore, that's what you get. One final comment. Is that my time?
They're playing you off
stage. That's my time. I'm ready to get off stage here. But, so that's really what I wanted to say. I think the funding is critical, and some short-term needs are really paramount. Thank you.
Thank you. Sarah Duff.
Hello, I'm Sarah Duff. Do I need to press a button?
You have a little talking person.
Talking person.
Yes.
Hi, I'm Sarah Duff. I'm an owner of Duff Johnson Consulting. I consult with patients, growers, caregivers, clinics. I've worked in 5 different clinics around Oregon. So I'm going to try to make it to the training subcommittee because I think that would just be good information. But I wanted to give a little bit of information I was able to look up pretty easily thanks to the stats that we keep for the Oregon Medical Marijuana Program. Looks like in 2005 we had 12,000 patients. At that time the fee was only $100 or $20 if you got the reduced fee. In 2011 that's when we increased the fee up to $200 for the maximum application cost, and we had 39,000 patients at the time. And I have nothing but respect for Anthony Taylor. I just have a hard time believing that there's no way to sustain the program with less patients than we have now. I feel like we should be able to if we had 12,000 or even less than that. And if not, we need to do whatever we have to do to make that work. I don't think increasing the cost makes sense. Back in 2012, when they increased the cost to $200, we had the highest fee, and I think we still do, for a registry program for medical marijuana anywhere in the nation. The costs at the time were $25 up to $150 in any other state. So I just feel like we maybe should think about decreasing the maximum cost of our application fees so that we could have more people participate. There are a lot of people that would be patients that just can't afford to be a participant any longer. I was one of those people for a few years, but luckily I've been able to recently, and so I hope that continues. Let's see, I also wanted to point out, I mentioned this in last Monday's subcommittee meeting for patient access, that we have a $4,000 dispensary license fee, and that is an insanely high cost. That's why we don't have nonprofit dispensaries. If we could decrease that down, that would greatly help the possibility of having those. I looked up the OLCC license fee for a brewery, and it looks to be $500, and a distillery is $100. How is it that we can't make our program less costly? This is a non-toxic herbal remedy. I feel like it is important to train our bud tenders to not give medical advice. However, I feel like we should be giving them more tools to be able to offer science that maybe could be offered, since it is somewhat of an over-the-counter medicine that is now being bought by a lot of people that can't afford to be a patient and can't afford to go speak to a doctor. Anyway, I just appreciate you all being here, and if I could be of any assistance in any way, I would love to help. Thank you.
Thank you. Sunny Sanchez.
Hi.
Keep pushing till the red light comes on. Middle button, first to the right of the mic.
There we go.
Hello. I'm Sunny, and I've done this once before, but I am a grower in Lynn County and a resident of Benton County, and I'm just want to say that I appreciate all of you coming here and taking the time to address the issues before the Cannabis Commission, and I just want to say good job, and I'm looking forward to seeing the draft that is that going to be made public, the draft that you present before the ledge? Okay, so awesome. That's my comment.
Thank you, Sunny. Missy Hopper.
Try to maneuver the microphone. Okay, I'm Missy, and I'm here as a witness, as a medical patient using cannabis. I was diagnosed at 11, which was 30 years ago, with a very rare brain tumor. A rare brain tumor.
I'm just gonna sit here. I'm just gonna sit here in case
No,
I have
I
to.
want you to do something different.
You're good.
There you go.
And I've had countless numbers of surgeries and chemo and radiation and a variety of different things throughout my lifetime. And I would say that cannabis has helped to save me, and it's also given me my quality of life back. And it's because my best friend is my personal grower who grows for me. I went from 30 medications to 3. Now that has to be a big savings funding-wise for the state of Oregon, because I'm on Oregon Healthcare. And, you know, if I didn't have my friend growing for me as my personal grower, I would not be able to go into a dispensary and say, because I'm using cannabis to stop vomiting that no medication could ever control. I'd go to the hospital multiple times a year with vomiting that took hours and sometimes hospitalizations to get under control. My best friend growing for me, just by chance, this is a note to research, by chance I was having cannabis in place of my anti-nausea medication, which I had 3 or 4 different kinds, that never worked. And we started noticing the cannabis is controlling my vomiting. For a decade now, I have not been to the emergency room for hours upon hours and a ton of money spent trying to just stop vomiting. That's all. And the vomiting can lead to other things, like I have bone issues, I have kidney failure, I've had kidney issues, I've had liver issues. I've just had a number of multiple things. And without my personal grower growing for me, I wouldn't be off all of those medications. I wouldn't be avoiding surgery after surgery after surgery, which again is saving the state a ton of money. And I could not go into a dispensary because we do not have research developed to the point where I can say, I need something to stop my nausea. And we've also found something that stops headaches. And I've had headaches my whole life, and everything under the sun. And when I was taking 30 medications, I had Vicodin, gabapentin, fentanyl, and Flexerol in those 30 all at one time. I could have very easily overdosed. I mean, just because you forget you've taken a pill. I mean, there's just so many aspects to having a personal grower who knows you, growing for you, able to test different plants and not restricted to a small number of plants where they can't even find out that there are these things to control the pain, control the nausea, and control the headaches. So I'm here as a patient saying the state will save a lot of money in the long run if they understand that giving people information about medicine, because most of our prescription medications lead to other problems and other issues and other diseases. And if you take a plant, I mean, you can hear I'm very clear. I couldn't have this conversation with you 8 years ago. I was on way too much medication. I didn't have quality of life. So that's my comment, is I have a quality of life and I'm living at 41 years old, and I attribute it. Plus, we were able to get rid of my tumor. And that's the note. And I'm willing to speak to anybody and everybody who wants to speak to me about how we've come to where I've gotten.
Thank you so much. Matthew Mendoza?
There's the button right next to the microphone there, Matthew.
Hello, my name is Matthew Mendoza. I'm a patient first and foremost. Here we don't hurt other people, pardon. I'm a grower for myself, and I grow for one other patient. I used to have a grandfather's site due to House Bill 2198, 1057. I wasn't able to get to the workaround. They had a nice workaround where if I shuffled some paperwork and found somebody else to be my grower, then I could have kept my grandfather's site and continued growing for my patients who are all on Social Security. Because I was unable to, workarounds they can't be evenly applied to everybody. So as a result, I wasn't able to continue growing for the other patients that were all on Social Security. I came down, gave testimony when I had the opportunity to explain that hardship. And I asked simply for a little place, since I've already reported to him, on my dashboard in the Oregon Online Medical Marijuana system, to allow me to report cannabis transfers to my old patients. They can't afford it. They can't afford it at a rec store. They can't afford it anywhere. The agency's response was beautiful and clear. It was, we need legislative change for that. So I've been waiting. I got really excited when everybody talked about these listening tours. No one's listening to us. So What I'm asking for, I want you to approach legislation and ask them to simply allow us to report to each other in the system. Any OMP grower should be able to report transfers of cannabis to any participant, caregivers, growers, and patients. So I've been out collecting signatures. I've been going to clinics and collecting signatures, and it says, "Dear Oregon Cannabis Commission, I support legislative change that allows any registered OMP grower using Oregon medical marijuana online system to record transfers to any registered OMP participant." I have just under 100. Anybody would like to come look at these, I will be officially turning them in later when I find the appropriate channels. And I'm going to collect them all year. I've designated 3 days a week to go into clinics, and I'm going to be collecting signatures all year long. I have just under 100. I have 96 signatures so far, and I've only been at it a week and a half. They're coming. Also, I did a little questionnaire: which agency should administer the Oregon Medical Marijuana Program? The OHA, Oregon Health Authority, OLCC, the Oregon Liquor Control Commission, or other. Some people have been wonderful. The Department of Human Services, I think that's, some said the Department of Agriculture. No one has checked OLCC. Nobody at this point wants to be governed by OLCC. And then I'm almost done here. And regarding fees, so that's $200 grow site fees I don't pay anymore into this program. My patients don't have a grower. They're on Social Security. I'm finding, just like this woman said, we're friends and family. We're down to single growers growing for themselves with one other people. That's what the statistics show. We're friends and families of these people. Let us transfer to them. And OLCC been able to grow for unlimited amount of patients. Their producers can grow for unlimited amount of patients. That's wonderful. No one stepped up, but when they do, OLCC, those producers should be paying into the OMP program the $200 fees that I do. And, I mean, if we need money, boy, there's going to be a big source of it if everybody gets their way and we turn it all over to OLCC. Shannon, you're wrong. I was at the Rules Advisory Committee. There was an absolute unanimous agreement that this immature rates should go
Well,
up.
that's not what I was taking.
Okay, all right. Well, I misunderstood you. That's what I interpreted you to say. And I'm almost done. Oh, and finally, there's only 11 OMP dispensaries right now in the whole state. That's why I would guess that people are going into the OLCC shops. We don't have anywhere to go, and I'm prevented from transferring cannabis to anybody. Of course, where are they going to go? They're going to go to a shop where you can just do it, right? So that's what I'm asking for. I'm asking that we be allowed to report our transfers into the online reporting system. I hope that was clear. I'm sorry, I was really nervous.
It was clear. Thank you.
Oh, and I'll be here every one and every subcommittee meeting saying the same thing over and over. And I'm going to keep bringing these patients with me, and I'm just going to bring more. So you have to imagine this room is at capacity right now with another 20 out in the hallway. Thank you.
Thank you, Matthew. All right, I move to adjourn this meeting.
Hey, I signed the bottom.
I know, but you didn't check the little box saying you want to speak.
Oh,
CJ,
I'm sorry.
Come forth and speak.
Thank you. I mean, I come all the way up from Salem to film these things.
I was feeling insulted. You didn't want to speak today. Let's do it.
Right next to the microphone.
I have one comment to put to record.
Hold on.
I'm Pete Kramer from Mercy Center, Salem, Oregon. I've been with the program for a few years, a couple decades or at least. I seen a lot of changes happening. I seen that we were being used as a cash cow for the health department. Seen a lot of changes. Fees, they're ridiculous. A lot of patients are low-income patients and they can't possibly come up with these fees. I talked to a friend of mine who was a lawyer, Brad Shipman, and he found that the state has been violating our constitutional right, Section 20. Everybody should be treated equally. I don't think the patients are being treated equally. When 91 was proposed and that, they said in writing, we would not touch the medical program. Look at what happened to the medical program. Growers had to sign out because all the restrictions of fees. The patients can't grow for themselves, half of them. I could rant and rage on, and all I could say is, I hope you do a better job than the other organizations. We were asking for research about the cannabis, but we never got any information back. It was talking to a wall. Thank you for being here and that, and have fun and go fly a kite.
That would be a great way to end this meeting. Sunny, did you have another comment?
I just wanted, I
did not, for the record, I did not use my 3 minutes. So I'm a strong supporter of the OMP, and I would just like to leave you all with one thought, and that is regarding recreational forces. I want to know if OLCC recreational forces are so compassionate, where are their medical bump-up canopies for patients? Where? So please don't streamline patients into consumers and into recreational consumerism. Please do everything you can to preserve the OMP program. Please. Thank you.
Thank you for all your comments. We really are listening. We have another one. Come on.
I didn't check part, but I felt it's kind of relative. My name's Eric King, and I am a former OMMP patient and grower, expired 4/20 of this year. Last year, I paid $600 to be a grower for somebody else and myself, and that's just not something I can do. The black market is not really something I look into either, but I'm just going to continue growing for myself because that's all I can really do. I don't know what avenue we should go towards, because there's always, somebody wanting money. But I mean, I can't sell extra to 11 dispensaries in Oregon if I had it. So I can't come up with $600 every year. I'd like to be a grower. But I really only live in a residential area and can't have more than 12 anyway. So I'm just going to keep it either at 6 and be an OMM patient grower, or just 4 per year. And I can't see paying $400 just for myself to get 2 extra plants. But I want to be back in the OMMP. I want to be back in the OMMP program, and I think it's a great it was a great program and it should be again. And thank everybody for being part of it, especially Sarah Dove, because I met her like 10 years ago. Thank you.
Thank you. Yes, one more? Then I think we're going to have to call it because we're over at this point. Yeah, thank you.
Yeah, my name is Morgan Delaney. Missy is my brother's patient. And we've survived since this program went into effect. We had over a decade where you can't receive anything in compensation. Everything is donation. Then we survived where you could only receive compensation for your resources, but you couldn't receive compensation for your labor. They're about to lose their house and lose everything. And these are disabled people that this is their only livelihood of not able to get out of the house. To have the recreational program come in, them able to sue to get the 2-year residency removed, to get mold testing removed, to have everybody bend over backwards to give them as big a canopies so that they flood their own market. This isn't about the Oregon medical growers flooding the market. They flooded the market. Okay, the 20 pounds, we're a commercial site. We're a commercial grow site. We could have 54 plants. We could max that out in like 14 plants a year. At 20 pounds to survive in a commercial site is not feasible. So this is not a sustainable thing. I think there needs to be a way where there are medical production sites that are given a different category than just this whole patient thing, and you're going to donate and based on how many patients. Because we're a commercial site, we could have up to whatever it is, 8 patients, so we could have up to 54 plants. So we're being capped out artificially in fear by their lobbyists because they don't want us to mess up their supply amount, but they are the one who's thrown out of balance everything else because of growers overproducing down south. And it's not medical quality. So if you want us to be able to put in the resources to create medical quality and the diversity of strains needed for a variety of medical ailments, then this needs to be looked at in a totally different manner because this isn't sustainable.
Thank you for your comments. And thank you all for attending and listening and making comments. So I would like to adjourn the meeting. See you next time.
Thank you.